Okay, I'll let you go out and interact.
All right, colleagues, why don't we get started? I think we have folks online virtually, so thank you. We have people from around the world and from other parts of Canada. It's that time of year where people do like to come from that can't travel to Vancouver. So we've just set up a virtual setup. My name is Kishore Wasan. I'm one of the co-founders and currently co-director of the Neglected Global Diseases Initiative at UBC. And I'm also a professor in urological sciences at the Prostate Cancer Center, where I do my prostate cancer research. So thank you very much for coming. And in a couple moments, I'm going to have Dr. Richard Lester talk about really the vision for this workshop and what we're trying to achieve today. And your engagement, your ideas, your thoughts on how we can move this onto a Canadian level is actually going to be quite important. We've got some really good speakers today. Some housekeeping items. We'll have food up there. We're going to have wine and cheese at the end of the day, so please stay for that. Bathrooms are just, if you go up and around the corner, bathrooms are always important, is there. I also want to thank our sponsors, because without our sponsors, we could not put this together. So Medicine Patent Pool, and Andy Goldman is here from Medicine's Patent Pool, and we'll be speaking a little bit later, so thank you, Andy. Doctors Without Borders Canada, and Dr. Adam Houston is here representing MSF Canada. And thank you, Adam, and you and Jason Nickerson from MSF Canada have been very supportive and provocative in how their views about global health equity and access, but have been national leaders in that area. And also Justin Mendoza from the University Allies for Essential Medicine in the States. Unfortunately, Justin could not make it today live. However, he's going to come on Zoom for his presentation. He's the executive director of UAEM North America. So I want to thank you all that. But we do need to give an applause to one really special person. I know she's hiding out there. It's actually Fahan, because Fahan has helped me put this all together. And without her, we wouldn't be here today. So Fahan's out there. I don't know where she is, but let's give her thank you, Fahan, for everything that we've done. She's done an amazing job. So we'll, as we get the day started, please mingle, talk, and I hope you enjoy the presentations and the program we have today. One last item, because we have the technology to do it, we are going to record the session. So I hope you don't mind. To our presenters, I hope that's okay. And we're going to post those on our YouTube channel and online. But more importantly, we're going to make sure we have a recording of today's morning events, not so much this afternoon when we do the workshop part, but this morning of these talks, so that we can circulate these to our colleagues around the country that could not make it today, because we want to make sure that they remain engaged. So we do have colleagues from McGill University, from Dalhousie, from University of Alberta, who just could not make it because they're dealing with internal things at their university right now, which I think we can all appreciate and understand with the times that we're now facing. But they have told me that they are engaged and want to be participatory as we move forward. So we're going to record it and send it to them. And please, if you're wanting to, please go ahead and send the link once we've got it done and the recording to people that you think want to be engaged and involved in that. So without further ado, let me introduce you to, there's a registry here, to my colleague and longtime good friend. I think we're still very good friends, Dr. Richard Lester. Richard is an amazing clinician, scientist, and has been involved in NGDI for quite a number of years, and has been director and co-director for a number of years. Does amazing work in Rwanda. Does amazing work in telemedicine, and it's been a pleasure, Rich, to be working with you, and hopefully we'll continue to work together over the years. But it was really Rich and Nancy Galini, and Nancy's in the audience today's vision for this workshop and for this kind of thing that we're trying to do today. So with that, I'll turn it over to Rich for some opening remarks, and then we'll get started with the program. So Rich, over to you.
Okay, thanks, Kish, Dr. Wasan, and all of the one big thank you, of course, he forgot to do is Dr. Kish Wasan, who really has taken the initiative behind NGDI and started this whole thing. So since he actually covered most of the individual thank yous and welcomes, that's great. I'm just going to spend a couple minutes talking about some of the direction, vision, and appreciation for what we're trying to achieve with this. We have some amazing speakers and people who've been working in the field who Keisha's already mentioned. So I'm Rich Lester. I'm an infectious disease physician at the University of British Columbia and Vancouver General Hospital. So I still do clinical work. I also have a lab, what I thought it was going to be a basic science lab. It's a digital health lab, so dry lab now. And we actually have a nonprofit and a company that does digital health internationally that started during when I was doing my postdoc in Kenya. So while working in Kenya on some of the HIV through the University of Manitoba, and one of my great mentor, Dr. late now, Dr. Frank Plummer, was looking at HIV resistance among commercial female sex workers in Kenya. And at the time we saw there's an opportunity for mobile phones in the revolution to say, how can we use that to attack the problem of the day? And the problem of the day at that time was HIV treatment adherence. It was being rolled out globally through first through the PEPFAR, what did it say, the US government's PEPFAR program, and then followed by Global Fund. But at the same time, people were worried if you don't take your medications, they're going to get drug resistance, going to ruin it for everyone. That wasn't actually true. And another colleague, they did some work that showed that adherence in lower middle income countries was actually at least as good as North America. But with the opportunity with phones to say, well, one of being adherent is about being connected to your care providers, having the support when you need it. So we developed a program. But through that time, and going from research and having incredible mentors in science, there were Dr. Connie Kalem, international, one of the top leading clinical trialists, giving advice, all these mentors giving advice how to do research. And we said, okay, let's do a trial to show how texting patients can improve their HIV treatment adherence. And I bumped into somebody at the World AIDS Conference, works for WHO Essential Medicines. And he said, oh, you really need to monitor like a hard outcome like viral load. So we got some funding to look at viral load in a randomized trial and found that just by texting and being in touch with people, they were more likely to be adherent to the medication, more likely to have an undetectable viral load. And that means that they could be one is they're going to live healthier themselves, and two, they're not going to transmit it to others, and three, they're not going to get drug resistance that's going to raise the cost for everyone. The reason I'm telling this story again is just about my interest in one of the things we're trying to achieve here. Access to medicines is many things. It's the medicines themselves, the basic research. Dr. Wasson, we're very familiar with Keisha's liposomal amphotericin B that has the potential to come to market for wealthy markets for treating antifungals, but it also has the potential to be used in very low income, very poor resourced, and hence the Neglected Global Disease Initiative, I think, founded out of that. And of course, Keisha and Dr. Bob Hancock at the University of British Columbia are co-founders of that, which really said, okay, this science needs to benefit everybody. And they founded the Neglected Global Disease Initiative at UBC in 2010 with that basic core principle that science and its discoveries should be for everyone and everyone to benefit. What I found in digital technology was going from research into services that are available is a huge challenge. And many researchers don't even think about it, actually. They just do their research because they love it. They love knowledge. They love discovery. They love getting grants. They love talking about it at meetings. But transitioning that into products and services that reach millions and billions of people is a completely other thing. And I've been trying that journey quasi-successfully with getting our digital health world out, part of World Health Organization groups and that, to try to get digital tools out there. But it's the same with medicines. The time from discovery to really being reached and touching people is incredibly long and complex. So without getting too much, because we can all have discussions later to get into the depths of it, what we're when Kish was leaving to UBC for a while to go to be the dean at the University of University of Saskatchewan, Saskatoon, to be the dean there, he asked if someone would fill in for NGDI. So I stepped in because I thought that's such an important advocacy element at UBC for global health. And that was really the thing. It was just about advocacy and the core principles they stood for, of course. And then so Nancy Galini, which is here too, and I, who's former Dean of Arts here, an economist. She doesn't call herself a health economist, but she obviously partly is. Is also had quite an interest in access to medicine and access to technologies in health, and we really tried to keep that core principle of NGDI moving forward to develop a process for UBC to be able to say, okay, let's take these principles. So I think we have Brett, who might be given the background later, from Brett Sharp from UILO has been renamed, right? Okay, you'll tell it later. Okay, so UBC did found before I arrived, the Global Access Principles, which are principles for the university that really, you'll hear the details later, but essentially about ensuring that technologies that are developed from the academic public funding and so on reach those who maybe can't afford it but would need it. And I'll just leave it at that. So it's about access and equity. But those principles need to be put into action somehow. You need a pipeline of actually things to be that those principles can apply to, first of all. And then you need all the complex steps to make sure that those become products and services that everyone benefits from. So building on those, we thought, let's get our colleagues in Canada and the world, but in Canada too, and say, maybe can the universities be one of the starting places that just make it a core principle, that it's just accepted that if you, especially public university, but even private universities and even private sector ultimately, can start to move towards saying if we develop science and products and services from that science that are going to benefit a lot of people, we have sets of principles that we can build on, share, and it doesn't become the exception, it becomes the standard. So hopefully from this meeting, somewhere along the way, we come up with some concrete ideas to move that agenda forward within Canada, within our partners there, within universities, within our good friends from the US who have such a big role in global health and have had, and hopefully that continues. I'll leave it at that. And from those from around the world. So the fundamental that we're trying to get to with some of our not just the speakers today, the attendees actually that are all going to participate in bringing these principles forward will hopefully at least move us closer to that goal. And of course, this meeting is just a meeting, so it should be followed by follow-up meetings and follow-up work that move us towards that agenda. So I'm going to stop there. I'll introduce, or will you introduce our next speakers? Okay, thanks.
Thank you so much, Rich. Okay. So let's see. Fahan, you want to help me maybe get this? See, without Fahan, I can't do anything. So our first speaker is Dr. Adam Houston from MSF Canada, and Adam will talk about perspective from Doctors Without Borders Canada. Adam's had an amazing career. He's one of the humanitarian leads up for MSF Canada. He's got an adjunct appointment, I guess, at the University of Ottawa, but he's actually stationed on the island in Victoria. On a personal note, Adam and his colleague, Dr. Jason Nickerson, who unfortunately could not attend today, have been very supportive of not only the global health access principles and equity that we're trying to achieve at UBC. Oh, thank you. Even my voice is young. But my kids said the house is quiet because dad's not there, so that's actually a good thing. So is the fact that they've been very supportive about the principles that UBC has put into place. But like Rich has correctly said, translating those principles is really one of the key issues. So without further ado, do we have his talk there, Fahan, or? Okay. I do see it on the screen here, but I don't see it on the big screen. So Adam, why don't you come up? Your talk is here, but I think we just have to get it to the big screen. Yeah, no problem, Douglas.
That's all right. I can riff for a minute here. I mean, it's very nice to be here. And I'd like to extend my thanks to UBC, to Dr. Wassan in particular. He keeps describing me, as he already has at least once today, being provocative. So I feel like I'm going to let him down a little bit today. In that, we're really here looking for practical solutions. I mean, we have been working, with Dr. Wassan on projects like the oral amphotericin B, which is a product that we'd love to see. We'd love to have available, for the people we work with. In terms of being really provocative, I know UAEM's here, so Justin, maybe we can do like good cop, bad cop as necessary. But fundamentally, these are kind of technical issues, about terms, about agreements, about how we're translating things like these global health principles, into practice. Well, we've got an example of tech transfer in practice. So let me see, what can I say? So I got my slide here. Oh, there we go.
Oh, there we go.
Magical. All right. So anyway, we have a bit of this. Anyway, that's who I am, etc. Are these both on? Bad way. So there is feedback there. Is this one actually?
Move the mic towards the speaker. Don't point it back the way it was. You probably get it whenever our mic's pointed to the speaker.
I see. Okay, I'm going to do that and be careful. Okay, cool. So it's working. MSF, we are fundamentally, we are a medical humanitarian organization. That's what we are. That's what we do. Our work around access to medicines comes out of, our work there. So when we're talking about being very supportive of, bench to bedside research, our starting point is the bedside. And, what we're seeing there, what we're not seeing there. What we're seeing at other bedsides, but not at the ones that we're at. But anyway, a little info about us here. I won't read it out. But, we're operating in over 70 countries, millions of consultations. And as you see on the map, all over the world. So again, this is really the starting point for us when it comes to bench to bedside research. And there's a lot of really great research here in Canada on things that we certainly think are really important. Where there's a bit of a gap is, getting that out into the world, and then getting that around the world to everybody who needs it. And, the starting point of this is, we're a big consumer of many of these products, right? There are health products that MSF really is one of the leading consumers of. So, we have a very large, procurement body, et cetera. So, we're in it from that perspective in terms of, the costs that we pay, the costs that we see, our partners, the local ministries of health, et cetera, are paying that, make really important products that do exist inaccessible. And so that is where, a lot of our work on these issues stems from. So things like, the MSF Access campaign for the last quarter century, things like our involvement in setting up the NGDI, the Drugs for Neglected Diseases initiative, and so on. And so, we're really interested in, a number of aspects here. One, that there are, conditions that we see all the time. This is where that very unfortunate conflation of markets versus patients comes in, where, there are products that many patients need, that don't exist yet. How can we encourage those to exist? The neglected tropical diseases and so on. There are, the products that exist, but, don't exist in forms that would benefit a lot of patients, right? The tropical heat stable formulations of things that don't require cold chains, formulations of existing products. And then, of course, there are the many products that maybe aren't necessarily associated with MSF and humanitarian action. But of course, the fact that you are, you've been displaced by a conflict doesn't mean you don't still need treatment for, your chronic condition, your diabetes, your cancer, etc. All of these products, that do exist, that, access in higher income countries is good, but, that are needed and are unaffordable or inaccessible for other reasons, registration, etc., in places where we're operating. So anyway, a little bit on our R&D engagement, some examples here. There we go, Keish, we put you first in the bullet points. The amphotericin B development, an oral formulation of AMP-B would hit a lot of these boxes for us. This is the kind of crypto that we should be investing in. We're talking about things like Canadian biomanufacturing facilities. And I know this isn't, a big focus of what we're talking about here today, but I know there are exciting things at a number of Canadian universities and kind of consortiums of Canadian universities that now have or are developing manufacturing facilities. So, that needs to be part of this question, whether it's the, new small molecule plants or that sort of thing. Where do these all fit in? We've been having these conversations quite actively around the publicly owned facilities like the BMC in Montreal and next door the clinical trial materials facility about things that they could be producing, right now instead of not producing anything, which is a different bit of a story. From vaccines to monoclonal antibodies, whether those are mAbs that already exist or ones that are in development that would fill a really important need. There's some exciting vaccine candidates that people are looking at in Canada. And then, there are other facilities like the NML, which I will return to. So, how can MSF, help be a catalyst for these sorts of projects? Some of this is, the issue of demand. We are working, in many of these areas where the need is greatest. We're able to highlight that. We're able to do things as we've done a number of times for Dr. Wassan, even just to say, we're MSF, we're operating in these places. We recognize the value of a product like this, if it were available. Going beyond that, because of our operations, we can give a bit of a picture of the landscape. That we've got some active projects right now, for instance, Lassa fever. The figures that you see for Lassa fever that are often quoted are a bit out of date at this point. It's not clear how accurate they are. That's a condition that it would be really great if one of the candidate vaccines got out into the world, that we're, really working on developing a much better picture of the burden of Lassa. And then, of course, there's clinical trials. I mean, MSF is actively engaged in a range of clinical trials, whether those are for new products, whether those are for new regimens of products like TB. We've been involved in a number of the recent trials. These are areas we're actively involved in. So, this is a bit of a question that I hope we'll chat about today. How can we work with tech transfer offices to facilitate common sense access licensing provisions? These are also issues that we're discussing, with the government, with MPs, and so on. We'll see a bit of that later. And here's some, our public advocacy op-eds, including featuring some of the other folks in this room. So, I'm trying to be a gracious guest and not pick on universities. So we'll pick on the NML briefly instead. So, but I really want to underscore that, on key areas, filling some of these global gaps, Canada's been a research leader, right? The filoviruses, the NML, I was really, been doing fantastic work on this for a long time. Where the gaps have been in terms of, getting this great Canadian research out to the people who need it, right? Some of you may remember literally 20 years ago, headlines in the Globe and Mail about Canada invents Ebola vaccine and Marburg vaccine. And, there's always a bit of a gap, between the press release and things actually being out in the world. But, there were a lot of avoidable errors, I'm going to say, in this process. And licensing was a big part of this, that, in the absence of sufficient supports for Canadian research, the pathway for Canadian government research, the pathway here was to out-license this. It was out-licensed to NewLink, who sat on it. It wasn't until the West Africa outbreak that suddenly there was renewed interest. That license got transferred to Merck. NewLink made a bunch of money off that without really doing anything. Merck, did get this product to the finish line, which is great. It's a great vaccine. It's, there's a couple of Ebola vaccines now, but honestly, this is the one that we want in an outbreak. But, it's also pretty much the most expensive vaccine that MSF uses. And, history's been repeating a bit. Seems like there's a new filovirus outbreak, every couple of weeks in the news of late. And, a number of these, Marburg, Ebola Sudan, we don't have a vaccine yet. And, some of including the Canadian RVSV candidates that have been around for a while. And that's, again, been a bit of a consequence of some of these licensing deals. Those have improved. Now there's some non-exclusive licenses, multiple organizations working on these. IAVI, a nonprofit, the AIDS Vaccine Initiative is probably the furthest along. It's good to see these things, but it would have been even better to see this done before. We also see this, down in the States. There are now 2 licensed monoclonal antibodies for Ebola coming out of NIH research. But there again, licensing has meant that there's these exclusive licenses to do 2 different organizations that are basically just feeding them into the US government stockpile. They're not really being made accessible where they're actually needed. So anyway, Ebola vaccine is just an example of, where we think that licensing could be better, where we could see, public funding yielding a public benefit more clearly. And, I think that's what we want to underscore today. And again, I said, I'm going to be polite. So I'm going to instead point to other people in the room who've written things, underscoring that university tech transfer has, for example, has failed to improve access to global health products during the pandemic. And, again, UBC, a lot of great research came out of UBC, feeding into important tools in this pandemic. There's a lot of nice press releases about the global access principles, a lot of nice press releases about many of these innovations. Venn diagram of those press releases is like 2 separate circles. We'd like to see that change. We're really excited to be working with folks like Kish to make that happen. These are, of course, conversations that are happening in Canada, both before the emergence of COVID and after, where we've seen this idea that, publicly funded research should have global access conditions, right? That's not saying there should be no IP. That's not saying things have to be given away for free. It's not saying any of those things. It's just saying that, fundamentally, there should be some global conditions to make sure that Canadian innovations, get out there, that they get to everyone who needs them. This is something that, we'll see in our current world. What happens with the pandemic agreement in May, if it happens and who's on board. But, this is an issue that's in there. One thing that has already pretty much been agreed upon within the text, right? There's other sections still being negotiated, but, is this idea that there should be obligations, binding obligations, bit wishy-washy language here, but nonetheless, obligations that particularly, in public health emergency of international concern, including a pandemic, that governments will have an obligation to have strings tied to public funding and access in those situations. That's a bit more limited than what I'm hoping we'll be talking about today. But again, it is a reminder that this is a live issue with legal obligations. We've seen some other interesting developments in this regard. NIH came up with very interesting and I think quite progressive approach to licensing recently. Unfortunately, if you look at the date on this, January 10th, 2025, some things have happened in the interim that we won't get into. But this is certainly not a perfect plan, but it's something that is worth looking into. Both as a zeitgeist, but also as as an example. And I think it makes some even in the purpose background there. I don't know how legible that is from that distance, but recognizing some important things, like recognizing the importance of having these sorts of licensing issues addressed in these sorts of access issues addressed in licensing agreements, but also, right, that this isn't a one-size-fits-all situation, right? That, different products, there's a different conversation to be had about different products, and, they were looking at a way of making that happen. Just have to do this for Quiche to be provocative. There are some other perspective. This was, in the build-up to, the March for Science that was happening all over our southern border over the weekend. In the lead-up, I thought this was very provocative comment. Talking. This was in Boston Review, talking about the NIH and how to get public sentiment. Backing the NIH that this is important, something to preserve. Something that goes beyond an abstract idea of, science is important to protect science, of actually, ensuring that the public more clearly benefits, more clearly sees the benefits to them of public investments in public bodies like this. These fortunately, we're not currently in a situation like that facing the NIH, but I think there are still lessons here. So, where does this take us? I think some of you were expecting some of these pictures either from us or UAM. But as a university researcher, who in health, who are you aspiring to be? And there are certainly many researchers who would aspire to be somebody like Jonas Salk and not invent the polio vaccine, but there's the famous patent. There is no patent. Could you patent the sun? Approach to IP that ensures that these important innovations were available around the world. And of course, this spilled over to other polio vaccines as well. Those of you in tech transfer offices who are perhaps some of you tired of hearing Jonas Salk's story know that the real behind the scenes story about the IP is a little more complicated than this. But nonetheless, that question of, can important research for global health be done, without patents? We've seen recent examples of that. In fact, Peter Hotez and his his COVID-19 vaccine that ended up being produced in India. Nonetheless, that's not, we're not here today to advocate for, well, there shouldn't be patents on things. Patents serve all kinds of purposes. IP serves all kinds of purposes, very useful purposes, in truth. But one of the questions is, what are those purposes, for your institution, for your researchers? And I would suggest one thing that is the wrong answer is IP is an end to itself. We need more IP. What does that mean and why? We need to protect our innovations. Great. We need to, have ways to get our innovations out into the world. Great. We're trying to make some money off of these. All right. Is that the end goal of your institution, or is it, the creation of knowledge and the dissemination of that knowledge? And here's even more CanCon that I'm sure some of you have seen. Let's go back to the most famous university developed, really the most famous Canadian health innovation a little over a century ago. So we're due for something equally exciting. Insulin. And, a little bit of, trivia. Note that it's only Collip Best actually on this. Banting's not on here. But, the assignment of this patent from the researchers to the U of T, and, the reasons behind doing this. And, we can say this about other innovations elsewhere, penicillin and so on. There are reasons to do these things, scaling up, taking those next steps, right? Penicillin, there's a reason that a number of people are on the Nobel Prize. It's not just the discovery, it's the scale up, all of these different really important aspects. But, in this transfer, in this assignment, I think it's fairly safe to say that Collip Best weren't thinking, how can we ensure that a multinational pharmaceutical company is able to price their life-saving product, out of reach of many people who need it? They weren't thinking that. That's not the approach we should be taking. Instead, we should look to some positive Canadian examples, although perhaps service to the empire is not how to phrase things anymore at all. But, talking about distributing life-saving products at minimum prices, getting Canadian innovations out to the world. How can we do that better? I think that's pretty much all I have to say. Obviously, this is an uncertain time in global health. It's an uncertain time in development of health innovations. This is a bit of a, challenges, but also opportunities moment, although the exact balance there, we can debate. But there, just kind of summarizing some things I've already said, there are still things that, still health issues that we really need solutions for. There are Canadian researchers working on some of these, which is fantastic. But, we need to figure out ways, again, to get these innovations the support that they need to get out there, but to get to ultimately everyone who needs them. And, common sense global access provisions, we're suggesting need to be standard in licensing agreements. Let's go beyond principles into, into action. Principles, then policies, then rules. I don't know. Let's ensure that we can do that. And, let's ensure that, the innovations coming out of all your institutions, that those get out to the world, but people know where they came from as well, to really, highlight rather than, how many patents you hold, how many lives your institution managed to save through its innovation. Thank you.
We're going to go ahead and hold our questions to when we do our afternoon session, because it's going to be a working session. But thank you very much. Adam, for a very good opening talk. And the reason why I say you're provocative, he has an incredible Twitter feed, which by the way, I learn a lot from. So, and oh, you're now on Blue Sky? Yeah, I can understand that. So our second speaker is Andy Goldman from Medicines Patent Pool. And Andy is going to talk about essential medicines and some of the strategies that are behind that. And Medicines Patent Pool, I think, played a big role in the development of UAM. Isn't that right? Isn't that correct, Andy? I think so. Maybe you can speak more. No, maybe I'm wrong about that. But I do want to say that they've been very supportive of developing a Canadian global health access principles and policy and equitable pathways throughout the country. And so I think that this is going to be important to hear what Andy has to say. So Andy, thank you very much. And also, he was major sponsor of the event.
Thanks very much to NGDI and to UBC and to all of you for giving me your time and attention. And yeah, I don't think Medicines Patent Pool had anything to do with UAM's creation. So Justin, please don't get mad at me for that.
Yeah, that's not.
It's okay. I wanted to tell you a bit about Medicines Patent Pool and what that organization does, and also to try to follow up with on what Adam was talking about, to give one example of something concrete, one type of provision that we've seen start to have a percolating amount of interest with other universities and institutions, because I do think that it is important to move beyond principles. Principles, having well-crafted and well-thought-out principles, are really important, but it's translating those principles into actual practical conditions that can work and that actually meet industry partners where they are in many cases. I think that's really, really important. And so I want to talk about that. So Medicines Patent Pool, apologies if I sound congested. I seem to be getting a little bit of a cold. So the MPP is a Geneva-based Swiss non-governmental organization, and it was created in 2010 by Unitaid, which is a large public health funder, and at the time was housed within the World Health Organization. And the mission, the reason that MPP was created was to increase access to affordable and quality assured medical technologies in low and middle income countries. And the mechanism that we were set up to use is voluntary licensing and technology transfer. And just to give some context to that, and I think Adam and others in the room will know this very well, at 2010 and in the preceding decade or even 2 decades, the HIV crisis was enormous, really mind-boggling amount of death around the world that could have been prevented. And in that crisis were a lot of very contentious fights about intellectual property and the role that it would play as an incentive for new technology, but also on the flip side as a barrier to access. And so in those previous 2 decades, you saw a lot of governments trying to act because nobody else would act for them in making sure that medicines could be available and affordable for the people that they needed to serve, who were dying. And so, you saw a lot of governments issuing compulsory licenses, which is a right that every country has in its patent law around the world. Almost every, I can't even think of an example where there's no right to issue a compulsory license. So that was the reality at the time. That was the backdrop. And so when WHO created and Unitaid created Medicines Patent Pool, it was to try to figure out how to address the issue of intellectual property and to unlock that barrier in an additional way. So not to replace not to say governments cannot issue compulsory licenses or you cannot have patent oppositions. This was meant to be a complementary mechanism to achieve access. And so at the time when we were created, it was very much to focus on HIV. And so the model, which you can see here, very simple. It was to negotiate licenses with the originators, with the patent holders, and in those licenses to negotiate form sub-licenses, which would be passed on to generic manufacturers. So Medicines Patent Pool is not a developer, we're not a funder, It's not a civil society organization, or, we have a very specific role here of using licensing to achieve access. So in these form sublicenses that are passed on to generic manufacturers, the ultimate goal is to achieve affordable access to quality assured medicines in low and middle income countries and to serve the people who need it. The terms of the licenses, I'll get to in a second. So each license is bespoke, but there are certain conditions which we build into the licenses in every case by our mandate. We have to. But the ultimate goal is to have a kind of win-win-win-win scenario here, where the originators can actually achieve access where maybe they didn't before have any footprint on the ground in countries, which is frequently still happens to this day. So they, at the time, they may not have put enough thought or had enough resources to actually do it themselves. So how are you going to actually do that? So this was at the time a sort of new concept. Low cost producers, generic manufacturers, they obviously have a stake here as well. They benefit by, from them. This is doing good, but they're also building their businesses. Governments and treatment providers and communities all benefit just from the drastically reduced prices from generic entry. And at the end of the day, we're trying to save as many lives as we possibly can. So these are just some of the features of our licenses, which are built in in every case because of it's actually in our statute. So we have to do this. So we're fighting in every negotiation. We're fighting for the broadest possible geographical scope, focusing on low and middle income countries. All of our licenses are non-exclusive. All of our licenses are transparent, so everything is posted in full on our website, and only very limited redactions for confidential, truly confidential business information. We have strict quality assurance policies written into our licenses. They have to be complementary to other mechanisms. So as I said, compulsory license is perfectly viable. We're not going to do something contractually that's going to abrogate the possibility of a country using its law in a different way, issuing a compulsory license, having a patent opposition. So generic manufacturers should be able to sell where there's no patent, right? So we're not going to use our contracts to block that. License management, so we have, extensive provisions about non-diversion. Technology transfer can be part of our licenses. And then because of our role in this, we have to simultaneously be offering a lot of assistance to the originators who are licensing and also to the licensees, to the generic manufacturers. So with the head licenses coming in, we have, many reporting obligations that we have to give back to the originator. We have to monitor all of the diversion, which is a huge concern for them. Obviously, they want to achieve access and affordability in low and middle income countries, but they frequently want to retain their high income markets. And so they're very concerned about leakage. So we have to do that. That's part of what we do, trade dress monitoring and so forth. The support to the licensees is intended to help the generic manufacturers to increase uptake. So we do a lot of assistance with, working with ministries of health, working with the WHO on guidelines and so forth. And we, over time, our mandate expanded pretty quickly. So from HIV in 2010, the mandate was expanded to hepatitis C and tuberculosis in 2015, and just keeps growing. In 2018, it became all essential medicines on the WHO essential medicines list, plus some that are not yet on the list but have a high likelihood of being on the list. During the pandemic, it was broadened to include COVID-19 technologies. It's now including biologics. We added a whole technology transfer team to the organization during the pandemic, sort of mindful of where medical technologies are going, more complexity. And so the small molecule scenarios of our early HIV licenses are starting to seem increasingly like the past. And here you can see over my shoulder, just a snapshot of what we've licensed and from who. So we have most of our licenses, as I said, are from the industry, but we do have some with universities for upstream technologies, not that many, but because we're not a developer, but we have some long-acting technologies. We have licenses from Johns Hopkins for sutazolid, which is a tuberculosis product, one license for cancer recently, and some work on maternal health. And the generic manufacturers in the beginning, when we started, the focus of, or the base, I would say, was obviously India. It's where a huge network of generic manufacturers exists, and it plays an incredibly important role. But over time, this, as with our expanding mandate and just sort of the recognition of need, our generic manufacturing network has grown significantly and continues to be a priority of focusing on regional manufacturing and trying to make sure that there's sufficient capacity. So you can see how this has expanded over time. And our impact in all this, I mean, it's fundamentally, this has saved a lot of lives. There's been a lot of generic medicines that have made it to patients that would not or could not have, or at least would not have as quickly. And the result of that is obviously a huge amount of cost savings compared to the originator's products, and deaths averted. There's just a lot of data about this, and it's been one successful model, not the only, but just one. So how does this connect to what Adam was talking about and why we're here, about access principles and thinking about access? And so several years ago, we added, when the strategy for MPP for 2023 to 2025 was created, added this work stream about upstream access. So everything I just talked about was about downstream. It's the products are already on the market in high-income countries. How do you make that available in low and middle-income countries and do it as quickly as possible? So we added this upstream access work stream because we know, I mean, there's a few important reasons why we did this, and then I'll get into what it is. We know that even in the best case scenario, when we are able to secure a license, that takes time. That's when we're successful. There may be many instances where we're trying very hard, and civil society is playing a role in this, and other stakeholders play a role in trying to get a license, and it just doesn't happen. But even when we do get a license, it takes time. To negotiate the license takes time. To find the generic partners takes time. For them to scale up and get the product out takes time. And so that is, in our mind, not good enough. We want to see that window of time minimized as much as possible. And we also know that simultaneously that the issues of access and affordability are enormous. And not just really across many types of disease areas. And it's not just neglected diseases. I mean, this is truly like, if you just pick your disease field, and there's going to be a significant amount of data showing how access and affordability in low and middle income countries is an enormous problem. Still 2 billion people across the planet who lack access to essential medicines. Cancer, just as an obvious one, there were, I think, 10 million deaths in 2022. 70% of those are in low and middle income countries. Maternal health, huge problem in low and middle income countries. I think 95% of the deaths related to maternal health are in low and middle income countries. And 6% of the population in low and middle income countries are pushed into extreme poverty because of out-of-pocket expenditures relating to their medicines and medical technology needs, meaning that they are forced to live on less than $2.15 a day. And that is, to us, just unacceptable. And so those are the problems. But I think, and Adam said this, and I completely agree, they're built into the fact that there is a problem is an opportunity. There is an opportunity here for universities to think about what is the role that they can play in changing that. And I don't think that they can do everything. I think this is as Adam rightly said, this is something that governments have a role, universities have a role, funders have a role, but there is something important here for us to think about. And so this is what I and others at MPP have been trying to do with this work stream, is to work, we frequently go around and talk to people about these issues. And we have one particular instance which sort of led us into this work stream. And Justin from UAM, I'm sure we'll mention this later, And it sort of formed a little bit of a backdrop to the NIH policy as well. So around 4 or 5 years ago, I'm losing track at this point, UCLA was taking a lot of pressure from UAM and other civil society organizations because they had developed a very important prostate cancer medicine with federal funds, NIH funds, and they held the patents, and then they licensed the technology out to a company that was acquired by Pfizer. And in the license, there was nothing about access. There was just a sort of, one sentence, broad strokes, the parties care about access. It was like that minimal, nothing at all that was going to sort of instruct what should be thought about. And so, fast forward down the line, the product ends up on the essential medicines list, and it has high prices in the United States. It's frequently the kind of drug that Bernie Sanders and others will point to as an example of, this was created with federal funds at a university. Why is this so expensive? And in low and middle income countries, there were access problems. So in India, there were huge access problems. The patent was successfully opposed, but because of the contracts and the obligations that the university had to actually go and defend the patent, even knowing and having it been pointed out to them that defending the patent in this situation is actually going to create more of an obstacle for access. And so, but their hands were tied because what are you going to do? So UAM was incredibly persistent, as many of you in the room know they will be. And through their persistence, they first were speaking to the administration, I think then the tech transfer office there. And at some point, Medicine's patent pool was brought into the picture. I think because of our experience with licensing and fluency with the language, but also because civil society is a stakeholder. So MSF, UAM, we frequently communicate with them about all kinds of things, and we will hear it from them when we're not doing a good enough job. So civil society is a stakeholder for us, but also industry, obviously. Like, we can't do what we do without industry. There are no voluntary licenses. So the fact that we played sort of like the Switzerland of this dynamic of just being like, okay, we have to work with everybody. We were brought into this picture to help and to try and figure out, like, what is the way that we can move this forward. And so what ended up happening was the tech transfer office there was very clear with us about that they wanted to move forward. They wanted to make their license template better than what it had before. And that was not hard because there really was next to nothing, as I said, but also was very clear with us that of the reality that they have to face when they're dealing with licenses, that, for many cases, the leverage for early stage licensing, of early stage technologies is very, very low. And so it's different. It can be very different from something where, a product is taken into clinical trials, or it's a pandemic context or even neglected disease context where, like, the parameters are different and there may be more opportunities to do something. In many cases, UCLA was telling us, like, the reality is they have very little leverage. And so if they put something in that is too prescriptive, the potential partner is going to walk away because there's many other places that they can go. It's not a seller's market, right? And so that was very clear to us. And on our side, and UAM and others, I mean, we want the change to be meaningful. So how do you do that? So what we came up with was something that it is not meant to displace any of the other approaches for that may be appropriate for certain types of technologies or certain situations. Certain situations you may say patents are completely wrong, or just the university is not going to assert its patent rights. That may be perfectly, like, the right thing to do in many situations. Pandemic context, like, you may very well need conditions that have more teeth, so to speak, because it's a pandemic, right? I mean, like, you want to get out of the pandemic, and people need what they need, and they need it fast. Those are sort of like different situations, but how do you do this for early stage technology where the leverage is low? And how do you do this in a way where that can apply very broadly, right? So no matter what the technology is. And what we came up with over a series of months with them and then discussing it with UAM, and then the tech transfer office would take it back on their side and speak with their stakeholders, different types of industry partners, was a very simple concept. And it had its origins in other approaches that are out there already. So Gates, for example, their global access program, CARB-X, and their stewardship, access and stewardship obligations for their funders. But what we worked out with UCLA was a clause that we called the Affordable Access Plan provision. And the idea being that you have an obligation in there for the licensee to submit its plan back to the university of how it's going to achieve affordable access for the technology in low and middle income countries. It does not say what that plan has to be. And that was very intentional. It says it could be, for example, through licensing, right? If it's something that makes sense and is easy for Medicine's Patent Pool, great. But in many cases, that's not the situation. It could be through partnerships. So it could be very much like what Adam described. If it's an obvious thing for MSF, like, there you go. Like there's an access plan. There are many organizations out there. And I think most universities have not, in my mind, done a good enough job of finding the organizations out there that can help. So the obligation is to submit the plan. It does not tell the licensee what the plan has to be. The plan does not get submitted until the product is about to be commercialized in a high-income country and achieve regulatory approval. That's there. I could get into the details of why this is different than the NIH plan, but save that maybe for later. The idea there was to be mindful of the fact that many licensees need time and are very explicit about the fact that they need time to focus on the R&D to actually get a product to be at the point where it will be possibly successful. And also that the reality is that access for early stage technologies, it might not even be clear. Like, what is this technology, or how is it going to be? Like, what is the appropriate modality or way of thinking about access for a technology that is, very, very early? It can be hard to say, and those things become more clear as you go along. The other thing that we put in here was this idea that the university can call upon what we called a designated entity to help them. So when the access plan comes in, they may not know what to do with it. The expertise that we see, and when I speak to universities or others, frequently in the offices that are doing this, brilliant. I've met brilliant PhDs, like incredible minds for science, licensing, lawyers. Like, there's a lot of brilliant people that I've met, but not all of them have sort of a global health perspective where you're thinking about this of like, okay, let's solve, there are a million problems beyond just the licensing, and here are the things that we need to think about. So the designated entity idea was the idea that you can call upon some other organization to help, to so that as an access plan comes in, if you don't know what to do with it, pick up the phone, call Medicine's Patent Pool, call MSF, call GuardP, call UAM. There's a million organizations out there, right? That can help. And that was important, so that, because we don't want this to just end up being a bunch of words that is, they just get swept under the rug when the time comes. So we actually really want to sort of mitigate the softness of this clause, which was intentional, with the idea that you have collaboration built into this. And that is the way that you're going to actually make a meaningful change using this clause. I don't know how many, I'm going to skip this because I don't know how many lawyers are in the room who really want to get into it, but this is the clause. This is the clause from UCLA. It's very, very simple. There's progress reports built into it, and the concepts of discussion with designated entity and so forth. After UCLA did it, so UC Berkeley followed up a few years later, adding it to their exclusive license template, which is online and public, so you can actually take the time to go see it. Theirs was almost the same as UCLA. It was very much the same, except that it added a bit where the scope of the access plan can go beyond low and middle income countries. And they added this highlighted part B, meaning that the access plan not only should talk about how are you going to address affordable access in low and middle income countries, but you have to also address certain underserved populations as defined by US Department of Health and Human Services in the United States. And I know I'm in Canada. So the reason I highlight this is to say that I think this is an interesting idea that could be modified depending on where the office is. It could be relevant for Canada. There are offices that we've spoken to in different countries in Europe where they're like, oh, that's interesting, like with that, because that's not Medicines Patent Pool's focus. We're not, by mandate, we're entirely about low and middle income countries, but very much aware of access and pricing issues in high income countries as well. I think I hit most of these key points. So the fact that it's not prescriptive is intentional. That was very much by design here. One thing I sort of glossed over, in addition to the access plan of like, how are you going to achieve access? The licensee should also specify when they submit this, where do they have absolutely no intention of commercializing? And that should, in theory, create a very easy, separate conversation. Okay, you have no intention of going here. Now we are going to all work together to find something. The third bullet point, this is a forward-looking approach about access. So, and it forces the thought about access at an early point, as early as possible. And this is different. Many offices that we speak to, they say, oh, well, our university does, non-assert. We have, so, many are thinking back to like 25 years ago when, there was a situation at Yale with D4T, right? An important HIV drug where it was like the students, this Amy from, who's now teaching at Yale Law, but at the time was a student there and who's really instrumental role for UAM and others, went to the university and was like, this drug came from Yale. Like, why is Yale standing in the way of access? And sort of forced Yale to reckon with this, and went to Bristol Myers Squibb and really changed the situation there. So I think many offices are thinking about that, and they think about, okay, well, we don't want to create the problem. So you have many offices say, well, we have a non-assertion of our patents. We will not assert. In some cases, that may be completely enough. In others, not. It's not necessarily a guarantee that the lack of assertion of a right is going to mean access, right? So what I mean by forward-looking is to say, let's not wait for a problem, or let's not just say we are not going to create the problem, but let's all, by collaboration, have these discussions and try to move access forward in that way. The designated entity concept I talked about. One thing I didn't mention, but so this is intended to focus on the licensed product. So the access plan has to attach to the product, the final product that uses the patent, not just the patent itself. The patent itself may be only one of many. And, it may, as technologies get increasingly complex, it may not be the thing itself that is like the important part to focus on. There may be all kinds of, know-how or other things that are really critical. So I think it is important to note that. Just the last 2 points are just, as I said about the origin of this clause, right? So UAM was there and was playing a really important role in this. So, it was clear to UCLA that whatever came out of this not only had to be workable for them and their industry partners, but it had to be something that UAM was going to say okay to. Otherwise, they were just going to keep fighting. And so that dynamic is what allowed this to move forward. So UAM gave the thumbs up. They're not putting it, Justin will tell you later, they're not putting anything aside about the other things that they ask for. But in terms of this clause, they said, okay, let's see how this goes. On the industry side, they vetted it with IP law firms, with venture capital, with, I was told, bio, and Amir from UCLA has been very public about this, about how he did this. And, I don't know the names of the people that he spoke to, but that's what he told me. And so we moved forward there. And that's been really interesting. And since then, he and other universities that have picked this up have all said, basically, there's zero pushback that comes from this because of so much thought that went into it about how to craft something that was not going to create fights, because we weren't actually to move the needle on this. So since that time, this is just a partial list, but many other universities have started either putting this into their license templates or have started piloting it. Many have told me or said publicly like they've had the same experience. In most cases, if not all cases, there's just been no issue. UC Berkeley, I saw Lala from UC Berkeley the other day, and she said very publicly, like we continue to have no issues. And when questions come up from licensees, we just have a conversation about what the clause means. They sit down, they look at it, and then the issues go away. But you can see, I mean, Columbia University has put into their template. Stanford told me the other day they put it into their template. And we're starting to see this clause being used on both sides of the Atlantic. In the Netherlands, you can see Erasmus Medical College, but also we know the University of Amsterdam Medical College has started using it. And there's several in Spain that are not on this list. IS Global from Barcelona, and the Liverpool School of Tropical Medicine has started using this as well. So I'll stop there. I know I'm out of time and I've talked your ear off, but thank you so much.
Thank you very much, Andy. That was an excellent talk, and let's thank both our speakers this morning, Adam and Andy, for wonderful presentations.
Okay. As for an introduction, I think Keisha's basically already kind of done it, but Brett Sharp is one of the UBC members of the University Industry Liaison Office, I'm still going to say. He might update us, but has been involved with the global access principles throughout, and plays a core role as someone in medicine, and the rest of us who might be in science. We often overlook or don't get to realize what goes on behind the scenes of our innovation and all these important factors we saw from the last two talks, which are actually incredible. So I'm not going to say much of it because Brett is going to really give a overview of what UBC Global Access Principles have been and further introduce himself. But just welcome. Thanks, Brett.
Yeah. This one works? Yeah, that's okay. I'll stay by the podium. So thanks very much for the invite, Richard and Keish. Much appreciated. And I very much enjoyed the talks this morning. The speakers seem to have fled the building. But I did want to comment on a couple of things. One is this talk isn't going to go into the medicines patent pool approach that Andrew just went through. I did want to give him kudos. I think it's an excellent approach, and it's something that UBC will strongly consider using in licensing in the future. And on Adam's talk, Adam's coming back, which is excellent, which is what I also really enjoyed. I did want to highlight, I mean, Adam, you carefully worded this, but I did want to make sure that it was clear that in the COVID vaccine, there is no UBC intellectual property. Nothing was developed here. There are no UBC-owned patents in the COVID vaccine. UBC didn't receive any licensing revenues. There is no license. Obviously, UBC has been one of the foundational inventors or creators of the innovation around lipid nanoparticles. It's really a hotbed of innovation here. We do have a lot of spin-off companies. There are a lot of patents relating to lipid nanoparticles, but none of them are in the COVID vaccine. But it does raise an interesting question, like what if they had been? Like if UBC had created the specific lipid nanoparticle formulation used in those RNA vaccines, how easy would it have been for UBC to assert control over a vaccine technology where the patents that were hypothetically developed at UBC were, at least 2 sublicenses deep and surrounded by a thicket of other patents? Honestly, it would have been very difficult. I'm not saying it's not something that we should have aspired to, but the business community would have pushed back pretty hard on that. Anyway, so those are aside. I did just want to call out, I think both talks were very interesting and great. So as Richard said, I'm Brett Sharp. I'm the Associate Director for Technology Transfer here at UBC. I have been involved with kind of UBC's formal, or at least institutional, global access principles since close to the beginning of them. And For those of you who are from UBC, which is probably many of you, just wanted to highlight the rebranding of the office. We're now Innovation UBC. This is formed from the merger of our entrepreneurship and industry liaison office groups. So this talk, I'm going to try to focus, give you a bit of a history, and I'll focus on some of the licensing strategy UBC does use. Okay, so again, I'm going to assume very quickly that not everybody's from UBC. And this slide is really intended to highlight the fact that UBC is a big place and there's a lot going on. There's a lot of research going on at UBC. And for this third point here, I also want to highlight you should never trust university rankings. Always be highly skeptical of them, particularly university rankings where there's a small asterisk next to them. So this particular one, though, I just wanted to highlight, this is a stock slide, that this small asterisk points to UBC coming third globally for creating a climate of social equity in our operations and research. So again, be a little skeptical of third, but it is something that's important to UBC. And then on the, very quickly again, like Innovation UBC, we've merged industry liaison and entrepreneurship. One of our core focuses is kind of on venture creation at the moment, but just wanted to point out there's a lot of activity, a lot of partnerships we're supporting, a lot of licenses, a lot of spin-off companies, a lot of economic development, et cetera. This is the final introduction slide. I apologize for taking so many slides on this. Here are Innovation UBC strategic goals. And again, I just wanted to highlight the last one of these, strengthening equitable engagement and partnerships. This is both kind of diversity, equity, and inclusion focus internally, but also, I think aligns well with our global access principles and our goals with respect to licensing technology. Okay, so on to the good stuff. This is the history of global access at UBC, where it all started. Really, it began back in 2005 when one of our top researchers, Dr. Brett Friendly, received a Grand Challenges in Global Health Award to fund ways of boosting the immune system to fight infectious disease. And this was funding from the Foundation for the National the FNIH and the Bill and Melinda Gates Foundation. And to their credit, they required that UBC develop a plan, a global access plan for the equitable dissemination of results from that project. So that's what really first started us thinking about this. And then shortly thereafter, and I assume unrelated, we were approached by the UBC chapter of Universities Allied for Essential Medicines, essentially with a question, what are you doing about equitable access to medicines being developed at UBC? Which isn't, I think fair to say something that UBC as an institution had thought about before. So this began a consultation process both with UAEM, with senior administration at UBC, with the research faculty at UBC, to try to come up with a set of principles which were published for consultation and then ultimately adopted in 2007. And I think, I can't remember if Richard mentioned or Keish mentioned earlier, UBC was the first Canadian institution to develop and publish global access principles. And one of the first, I'd say, in North America. There were others before us, of course. And one of the things that I still find surprising is there's still, we've seen some good examples. Andrew's slide had some institutions who are clearly taking this seriously. Certainly in Canada, not many institutions give global access a thought at all. McGill's pretty good. I think maybe U of A, but I don't think, to my knowledge, anybody else has published principles or really thinks about it in their licensing practices. And they should. Okay, so the principles themselves. So I won't read this, but there's not much text. I just wanted to point out that the goal is to maximize global impact and ensure fair access. So those are the broad overarching goals. And I should note that the actual principles are on the next slide. They're not prescriptive. They don't tell us exactly how to do things. They're not specific to global health either. These are for any innovation that could be useful in a appropriate vulnerable population or community. But the principles themselves, again, very high level. We will promote global access by entering into public-private partnerships to develop new technologies to benefit the developing world, prioritize environmentally friendly research, ensure value return to countries of origin, and endeavor to ensure that underprivileged populations have cost access to UBC research innovations. So again, very high level, not prescriptive, the principles. So here's hopefully the most important slide, or the most interesting slide. So what do we do to try to ensure this? This is the tricky part, right? And again, Andrew, I'm not sure if you were in the room at the time. the medicines patent pool approach, excellent. Like it's something UBC would use. It's really good. So I didn't go into that particular approach because I realized you were talking before me and I wouldn't do it justice. But the first thing I did kind of want to point out is when UBC is negotiating licenses for its technologies, we're almost never dealing directly with a pharma company. We're always dealing with small biotech companies, usually startup companies. And frankly, whereas if you're dealing with a pharma company, they're tough, like they're aggressive, they're tough, but they usually understand global access principles. Like if you get the right group in the right kind of development area, you'll end up using their template in most cases, but you know, their understanding of global access. Your small companies are paranoid. All they're thinking about is, yeah, what is UBC going to put in this license that's going to delay or mess up my ability to either gain a funding round from an investor or be acquired by a big pharma or potentially enter into a sub-license. And they're frankly, with deference and respect to many entrepreneurs locally and across Canada, they're less sophisticated in these like quite reasonably. Like they're business people. They're not immersed in global access. They just want to frankly, they want to make money, and they want to make sure that they can sell their company when the time comes. So it's challenging. It can be challenging. So what do we do? Some of the obvious stuff. So UBC doesn't charge a royalty or any other fee for commercialization in developing world countries. I don't want UBC to get paid from those sales. I don't want UBC to contribute to the ultimate cost of the product in those countries. And I should mention that, you know, ultimately, you know, making money is nice. Like if I make money, my bosses are happy for the university, it's good. But the most important thing for any institution really is its reputation. And, you know, the last thing I want is the front page of the Vancouver Sun saying, you know, the innovation UBC or UBC is driving up the cost of a malaria drug or a leishmaniasis drug by charging a tax on the sales in a developing country. Secondly, UBC essentially never files patents in low and middle income countries. And we retain control of the patent prosecution process in terms of the ability for our licensees to do so. So if a licensee wanted to file in a LMIC, they need UBC's approval, and they need to justify why that was actually beneficial to a global access principle. And again, like Andrew, I think mentioned this, described it much better than I will. Patents aren't the only part of this, though. Like ultimately, there'll be more patents than just the UBC patent, as I just kind of described in the COVID vaccine sort of thing. So the terms of the license really need to extend beyond patents to products. And that's where it gets more challenging. Excuse me for a second. Okay, so generally speaking, we try to include terms that require at-cost access to the technologies, the products that read on the patents that we're licensing. And at-cost is a challenging, frankly, difficult to negotiate term. That's one of the reasons why I think the medicines patents pool approach is a good one. Kind of delays and offsets all these things to the future. But really, it means, you know, the licensee can recoup the cost of manufacture. They can recoup the specific regulatory costs for that country. So not the costs of obtaining approval in the US or Europe, but, you know, in the specific country that they're selling into. We want to, you know, essentially make sure the licensee can't profiteer in these vulnerable populations. We may also include field of use or jurisdictional limitations, like a license might be specifically to North America and Europe, or North America and Europe and Japan, and not provide the licensee with access to or the use of the patents in other countries. We'll often include mandatory commercialization or sub-licensing in developing nations, and here it's like, it's probably misphrased this. You can't force a company to commercialize in a particular country. But what you can do is say, well, if you don't, this is going to happen. And in most cases, we'll include language that says, okay, you're not commercializing in a timely fashion, the license becomes non-exclusive. Or UBC kind of gets granted back what they call step-in rights, where we can UBC can then grant licenses ourselves. Sometimes these may be to qualified humanitarian organizations to sell the products for humanitarian purposes. So a couple of slides on where we've applied this. This is kind of the first example, and Keisha's mentioned it before, and it's a really good example. Right from the beginning of the Global Access Principles, Dr. Wasan had developed a new oral formulation of amphotericin B. We licensed this to a local company called ICO Therapeutics. The idea was they would develop the drug for developed world applications as an oral antifungal, and in developing world applications for visceral leishmaniasis. The licensee kind of required ICO to make best efforts to serve the developing world applications. And if they didn't, the license would become non-exclusive to the extent UBC needed to commercialize it or license it elsewhere for these purposes. I should say ICO were a great partner. Like they really did make a good effort at this. It's tough. You know, they were formed in 2008, which was at the time a challenging funding environment. They gave it a good go, ultimately couldn't raise the funds. The license was amicably terminated just last year. They're now focused on other opportunities. And we have a new license to Elucidex Canada. And again, similar kind of global access type terms in that license. And we're looking forward to Elucidex's success, hopefully. And I should say, you know, frankly, relicensing a technology that hasn't been funded is really hard. Like it rarely happens. Like if somebody comes back to UBC, it's really difficult. So credit to Quiche and to Elucidex for taking this on. I think it's wonderful. Another example, so Birch Biomed, they're developing. So this is an example where they're developing an anti-scarring drug. And as far as I'm aware, this isn't a kind of a neglected global disease, but it is a globally prevalent scarring. And this is scarring from burns, from wounds, from surgery. They have an antifibrogenic technology currently in phase 2-3 clinical trials. The license requires cost-based pricing in the developed world, and UBC maintains step-in rights. So, you know, if they don't commercialize in the developed world in a timely fashion, UBC can step in and grant licenses to the UBC patents. It's also not all about drugs. So this is a great example, Arbutus Medical. This came about, I think, in 2000, I'm going to get the date wrong, 2012, I'm going to say, it might be wrong. Some students in our engineers in Scrubs program were talking to some surgeons and kind of realized that there was a problem with surgical drills. Surgical drills apparently cost, at least at the time, $20,000 to $30,000. They weren't readily available to surgeons in low resource environments. So they created, this isn't, I don't think it's what it looks like, but it's kind of an artist's representation of the drill cover. It's a sterile drill cover that can convert your home hardware drill into something that can be used in a sterile environment. They've had tremendous success. It's been used in over 100,000 surgeries all across the world. The best strategy for UBC here was to get out of the way. So, you know, UBC IP assigned it to the company, go for it. Like, they were driven individuals who were trying to do this for the right purpose, right reasons. And finally, so UBC has received some recognition for this, I would say. So here's, again, be skeptical of rankings. But we do consistently rank high in the universities for Allied Essential Medicine's Global Access Scorecard. We've been certainly the top institution in Canada since its inception, still are. One of the top schools in the world. We've gone from an A to a B. I don't know why we're not doing less, but maybe Justin knows. But again, like we have received some recognition for this. And I think that is it. I'm happy to answer any questions, but I think Quiche wants us to wait until later.
Thank you very much. Thank you so much, Brett. Yeah. So our next speaker is Justin Mendoza from UAM. Is Justin online yet, Kristen Douglas? Okay, you're gonna. So Justin is coming from the US today. He unfortunately could not make it up here, but is kind enough to present online with the advantage of Zoom. And we're just getting him set up. So Justin is the executive director of UAM North America, and I now know why I was confused with MMP and UAM. So my apologies, Andy. It's because you guys were working together on that one project, and you mentioned that. So that's fantastic. So let's see if we can get them up.
And just one moment.
Justin is also UAM.
I'm
is
just
also
struggling with a
sponsor of
camera issue,
of this
so
workshop.
I'll be right on.
And they have been a very strong, as you know, huge advocate around essential medicines around the world, and so on. So, Justin, can you hear us?
Yes, I can. Can you hear me?
Okay, can we? Is your microphone on?
Yes, it is.
Okay, I don't think we can hear you though.
All right.
Oh, there we are. Can we hear you? Go ahead, say hello, Keish.
Can you hear us now? Or can you hear me now?
Yeah, we can hear you now. So I've just
Excellent.
introduced you. So thank you so much, Justin, for coming on. And I'll turn it over to you. If you've got some slides to share, I'll let you do it from your venue. So welcome.
Wonderful. Thank you so much. And thank you to your entire team for putting together this conversation today. It's been amazing tuning in from here, and I'm excited to chat with you all a bit. Okay. All right, I believe screen sharing should be working now. So I'll go ahead and get us started. So I'm Justin Mendoza, as Dr. Watson just introduced, and I am currently based in Michigan. Apologies for not being there today with you all, but I am the executive director for Universities Allied for Essential Medicines North America, and I just wanted to start by saying it's just really excellent to see and hear a group of experts in technology transfer and global access talking together with civil society and gathering at a moment when global health as a whole is kind of in a big moment of flux. And to hear you all there together solving some of the major concerns and issues is just phenomenal. And so I just want to give a huge hats off to NGDI for organizing this event, to all of you for participating in this event. And of course, I do send my regrets for not coming in person. It was bad timing for family reasons. But my background, just by way of introduction, previous to, well, really, I've been with UAM in some way, shape, or form since I was a student myself. I started with our organization in 2010 as an undergraduate student, continued on in graduate school, focused on international trade. I wasn't actually on the report card project or any of the other pieces that you all might be as familiar with. Over the years, I've worked with big names in global health, including Partners in Health, working on their government affairs side of work in the US, and also working with Public Citizen on the access to medicine side of work, and Families USA, another US-focused organization. So my aim today, and what I was asked to do to present to you all, is first a bit of a success story about Cetezalid. And then I think we've been hearing about affordable access plans this morning, and I just had a couple of things I wanted to add to that discussion while you're considering various approaches that you all are taking and thinking about in equitable access. So just a brief bit, I'm going to quickly rewind to 2001 to remind you of where UAIM comes from, our mission, and then talk about the newest pieces that we're working on, and the success story around Cetezalid and Johns Hopkins. So this will be the quickest rewind ever. As mentioned earlier by Andy and I think even referenced a bit before that, here is kind of the origin story of UAM in brief. Stavridin, or D4T, one of the key drugs in the HIV/AIDS cocktail, AZT, came online in the 90s, was a life-changing medicine, right? This was the Lazarus effect for people with HIV, going from kind of a doomed state of no treatment to a very real possibility of sustained life. But the problem was, at the time, it was about $10,000 per person per year. And our slides mentioned South Africa because Amy Kapczynski, our founder, as a law student, had actually traveled to South Africa and spent some time there with Treatment Action Campaign and actually MSF, and had heard about this medicine being far too expensive to use in the field, clearly making it unaffordable for folks and tying it back to really what organizations on the ground needed, which is for the medicine to have an alternative. At the time, global advocacy organizations, MSF, doctors, well, they are Doctors Without Borders, and a couple of other groups had started, including Knowledge Ecology International, which is based here in the States. They had all started to talk about what it would look like to create a generic version of stavudine, something that could be produced actually by an Indian pharmaceutical company and sold it for just $1 a day. Well, they discovered in this process that actually Yale still held a key patent on the drug. And at the time, the university's hands were tied. The university had a licensing agreement signed, and that agreement tied them to the licensee, of course. And at the moment, it had no alternatives for access, no non-exclusive provisions, or an ability to claw back. So what we ended up doing as UAM at the time is working with the original drug discoverer, hosting protests on campus and making a lot of noise about how this medicine was patented on the university's campus with university researchers working tirelessly, and then, of course, licensed to a smaller biotech and then eventually Bristol Myers Squibb for exclusive production and costs. And we have freezing slides. We won is ultimately what the next slide would show. There it goes. We continued pushing and pressuring folks, of course, through this work on D4T to lower the cost of drugs, to lower the cost of stavudine in particular. And we worked really hard to push the university and Bristol Myers Squibb back to the negotiating table. And the ultimate piece here that really came out of this was a 90% drop in the price of D4T virtually overnight. And it let tons of organizations that this slide is old. Someone a long time ago said MSF in particular to treat HIV in South Africa, but really was the beginning and the foundation of a lot of this conversation on access to medicines. And since then, basically what we transformed into is an organization founded really after the fact. We, following the conversation on D4T and the pressure that we saw students able to exert on the university, on the licensee, we realized that, well, if we go drug by drug, university by university, it's going to take a generation, maybe 2 generations, to change the paradigm on access to medicines, to get to the point where there's a room full of experts at UBC talking together about how we do equitable access. We didn't envision the room that you're in right now having a way to exist without our organization being created. So we actually established ourselves as a nonprofit organization. This is our current mission, which is actually our 3rd mission from our 3rd strategic plan. But really our point is to promote access to medicines and medical innovations and to ensure that university medical research actually meets the needs of the people worldwide. And finally, of course, because we are founded by students, we want to empower students, which comes with its own kind of caveats. Beyond that, though, here are our values. We view universities as entities with a social compact with society, as an institution that has a responsibility to make sure that innovations are available to everyone. And we believe that students are uniquely positioned to be part of this conversation. The other values are just there and listed as well. But I think you all know this quite well, but why universities are important. These 2 stats are very old, but they actually are still true based on any review of the industry in the last few years. But depending on whether it's a biologic product or it's a simple molecule, between a quarter and a third of new medicines actually originate in university labs. And the 15 of the last 21, technically, if you look at the last 21 greatest therapeutic impacts, now it's actually 16 of the last 21 were actually developed through publicly funded research at universities. And to put a finer point on that, research now shows us that the NIH itself, looking at just US funders, not even accounting for CIHR's great impact on publicly funded research, but the NIH itself has contributed to 100% of the medicines on the market now, whether that's through clinical trial support, direct early scientific research, or other pieces there. Of course, with a changing dynamic in the US, who knows what the next generation of NIH funding will do or the next generation of drug research is. Personally, I'm keeping my fingers crossed that CIHR fills the gap. And of course, this leads us to, over the years, one of the tools that we've created and started innovating around is the university report card. We just saw a preview of it from the UBC team, so thank you for bringing that forward. And of course, UBC has been one of the top-ranked universities on our report card now through 3 iterations. Johns Hopkins, in our very early report card, this is a screenshot from the 2013 report card, was ranked top in North America. And at the time, they were the biggest recipient of public money worldwide. I believe they're no longer the biggest recipient. Honestly, many of you are competing with Johns Hopkins. But at the time, Hopkins was kind of the top of biomedical impact from our assessment. And when we started looking at this and thinking about what that means, it kind of fell hand in glove into a conversation about a couple of other pieces. This is just some praise from the late Dr. Paul Farmer. We'll skip that. And we'll skip this. Okay, but at the time in 2013, the Center for Tuberculosis Research at Johns Hopkins was really starting to invest and look at multi-drug resistant tuberculosis and what could come out of new innovations that were happening on campus. And in November of 2013, actually MSF, the Access Campaign, reached out to us and told us about Sutezolid, a promising new drug at the university that was patented both by Hopkins and another patent by Pfizer, which was a follow-on secondary patent, of course. And at the time, they were talking about exclusive rights to Sequela, a private biotech company, and we saw this as a potential barrier to future access. And so we started having conversations, researching the product, trying to understand what role the university played versus what role private industry played. As all of you are very familiar with, of course, it's a partnership. It's certainly never just the university, but an actual partnership to start working on this product. In 2015, a university student at our chapter actually wrote the first op-ed, just talking about how Hopkins could do even better than being the best in the world according to our rankings on university access policy in the 2013 report card, and started talking about how we could really license Sutezolid as a product. We also went to some prominent alumni, Jane Andrews, who happened to be a UAM alumnus, but also a researcher and alumnus from Johns Hopkins, was able to write an op-ed as well, talking about Sutezolid another year later. And then, of course, in the end, we're actually pretty lucky. We had gotten to know as an organization Stephen Lewis, who was just friends with the university president, and we formed a coalition with NGOs, Johns Hopkins students, alumni, and Stephen Lewis actually called the university and had a meeting to talk about what it would look like to rethink the licensing of Sutezolid and think about global access and equity provisions. And luckily, I mean, once everyone was in the room together, the university shares the same exact goals, right, that we do in terms of access and equity here. And it ended up being a win-win. In the end, we were able to garner some signatures, had a conversation, really led to a push here that finally resulted in the university being one of the first American universities, or first according to the slide, I believe just one of the first in reality, to license to the Medicines Patent Pool or come into a licensing agreement over Sutezolid, and start building this kind of new partnership. And then they actually announced a first sub-license shortly thereafter in 2017, with the TB Alliance. And here's a quote from Greg Perry, the executive director at the time of the Medicines Patent Pool, talking about these pieces. And what I love about this, and I think is the major point when we talk about Johns Hopkins' role in this, UAM's role, other NGOs' role, is that ultimately the university set the tone here. In 2017, Hopkins signs a licensing agreement with MPP. A sub-license agreement comes up through the Medicines Patent Pool's mechanisms, already getting us a little closer to access. But of course, and this does get worldwide acclaim from the WHO, but maybe the greatest part of this is that set the tone for Pfizer to also reach out and license to the Medicines Patent Pool on the same product. So now the IP, the know-how, and different pieces that were critical to the further development of Sutezolid with equitable access in place were laid already. The foundations were laid by the actions of university technology transfer folks at Hopkins who led the way, and paved what could happen here when it came to Sutezolid. Now, the drug today is still in phase 2 clinical trials. As we all know, this all takes a long time for drugs to actually make it to market and for products to be finished. And I am using drug too loosely there. I just mean any medical product. So of course we're still ongoing and waiting to see what ultimately will be the access impact of this work. But it's set on such a foundational or positive foundation, really, because we were able to work together with university to get to this point, to be able to set the tone for access to this product and to see a major producer of the product, a major pharmaceutical company that was also invested and holding some IP, jump in and follow the lead of that institution that received so much public funding and had, of course, the academic rigor to start the process. And I really raised that point to say no one at UAM is under a false impression that universities are ultimately the controller of all IP related to a product. No one, well, maybe some of the newer student leaders, but we train them so that they understand the context over time. No one really coming into this space across civil society believes that either. I mean, we heard that from both of our folks this morning. Ultimately, though, you can set the tone, and your tone matters. You are able to speak with both a moral conscience as well as the public in mind when you're setting the tone for how technologies should be licensed and handled when they originate on your campuses. And Hopkins did that here. Now we're at the point where in drug discovery, we'll see if this drug makes it to market. And if so, we will see what access and affordability looks like in the long term. But all of this kind of gave us a marker, and you already heard a lot about the Affordable Access Plan and how that came together. So I'm going to fly right through these, not in deep detail, because actually I think Andy Goldman's presentation is phenomenal and explained the details of it quite well. Of course, and it is MPP's product that we just helped kind of usher along. But for us, it ushered in a new era for UAM of working with universities toward access rather than working as an agitator, protesting on the sidelines and pushing. We believe that we can work together to build partnerships and grow on access and affordability. So you've already heard a bit about the Affordable Access Plan with the University of California, Los Angeles, and we are continuing to work to get the entire UC system to consider access and affordability provisions. I'll give you an updated list of the universities we have a record of, though I will say it's not a comprehensive list of even those we're aware of. It's just the ones we have permission to share about in different forums. And you already had a really excellent summary of this Affordable Access Plan, so I won't dive into that right now. But for us more broadly, affordable access plans are an exciting new development because of this. They're they're literal model language. In the past, UAM has approached many of your institutions, as well as many institutions around the world, with just principles and concepts and ideas, which we love. We think the principles are important and critical. But as Andy pointed out earlier, UCLA's ultimate kind of long-term effect of just thinking about principles was to have just a simple line that says that both parties will think about access, which isn't enough, right, to really have the conversation and really drive things forward. This creates and asks for an affordable access plan to be produced by the licensee and reviewed by the university upon approval. A major difference with the National Institutes of Health's proposal on affordable access plans is when the AAP would be presented. It's earlier. And I'm fading their exact time period, but it's earlier in the drug development process. Well, this is at approval, because really, we don't expect universities to have capacity to check in with licensees at every single phase or something like that, like the NIH does. In the end, the plan can be accepted, rejected, amended, discussed. There's tons of different language in there that allows for a conversation to happen, but the question then comes down to how is it actually enforced? And that depends on the other tools used by the licensor. So UC Berkeley has a socially responsible licensing framework and model in their template license available on their website. They're an example where, if they're unhappy with an affordable access plan, they have other provisions they could use. And they're already in the template in the model. It creates a check. And for us, that's a really important piece. It gives universities another check, another moment to be in the conversation around the ultimate access and affordability of the product. And, you heard a couple of these pieces anyway, but I think that these are, of course, I have a typo, so I apologize. But I think that these are some major points for us. It's not facing backlash yet from licensees. So far, universities that are using this are reporting back positive conversations. It's not scaring away investors or scaring away small biotechs who would be the next phase. In fact, folks are not even providing red lines to the affordable access plan. So it's kind of exciting. Folks are willing and able to sign on. It's not prescriptive rather than prescripted, but prescriptive, just like Andy was mentioning earlier. So it does give that flexibility. Since every technology is going to be slightly different, it makes sense to have a flexible plan. Biggest con right now is that it's going to be at least 5 years from now before we see the first affordable access plan, and that's going to be at UCLA, the first university to implement, and that's because it's at approval. So 5 years is being very generous and hoping that everything goes exactly as drafted in a clinical trial, and well, all 3 phases of clinical trials at approval. More likely it's longer than that, but 5 years is kind of the best case scenario we could imagine. But I do think, and I want to highlight that there's an opportunity here because this is still new policy. Affordable access plans don't yet have a kind of model or a standard. We don't yet know what these plans will look like from licensors or from licensees when they send them back to the university. And I think that creates a space for you all as folks who are thinking about these issues, dreaming about, or not even dreaming about, like literally understand from your own licensing experiences what barriers have existed and what kind of new limits haven't been tested yet. I think there's an opportunity to create a model of what an affordable access plan should be. Something that could be shared among technology transfer experts, maybe published, maybe not. That would be up to you all strategically, but something that would let you measure the success and kind of accessibility that actually comes through on an affordable access plan once it's been submitted. And that's something that I think is really the next phase of this work that I'm hoping to see folks pick up. And of course, we're right there, ready to be partners along the way and work on this as we go. All right, finally, I promised this earlier. Here's the universities that have allowed us as UAIM to share that they are utilizing or talking about affordable access plans. And it's a smaller list than those who actually are utilizing or considering affordable access plans, but these ones here, that's most of the UC system. And it's possible more have been added. But, as I said, these are just the ones with permission. That's most of the University of California system. That's Yale, Columbia, Harvard, and University of Michigan. University of Michigan is actually about to go very public with this, so we're only previewing this by about a week. But all of this is coming together now, and we're excited to see this growing list of universities jump into utilizing the Affordable Access Plan language as a way to address access. As I mentioned before, Berkeley has other policies in place. Columbia has other policies in place as well. Yale as well. And those are just the ones that I know of off the top of my head without preparing actual talking points. But it's only meant to complement existing policies and build upon them rather than replacing what you're already doing and thinking about. And it's a huge benefit that we think to the space. Finally, I just want to close on one final piece, which is for those who have been following us for a long time and wondering what's the direction UAM really wants to go in, what do we really want to see folks do, and what's kind of the cutting edge? Because I'll be blunt, the 9 points that came from Autumn have now been reviewed and by George Contreras out of University of Utah, and they don't work. Even if you signed on to the 9 points to consider in licensing from Autumn, the 9th point was global access, and not a single university around the world has utilized in a meaningful way that point. We fear that the statement of principles and strategies also developed through that process and that we endorsed as an organization also doesn't produce any real yields. We think some of your global access licensing policies are fantastic, and so they can really build, like UBC's approach. Actually, McGill had one that was very public for a while. It's no longer posted. But that one also, we thought, set a really fantastic tone. And those frameworks and policies are great. We'll have to see how effective they are long term. But one of the biggest things that we took a moment and tried to review over really the last few years is, what does it look like for technology transfer to be changing in general? And we've released an equitable technology access framework. This you can think of as a really broad guide and imperfect, I will admit. It was developed, we've actually are taking the steps right now to refine and further develop the ETAF to make it more specific and more built out. But this technology access framework, the idea is to address these 3 goals: improving global equitable access, promoting development of health technologies, and improving transparency in health technology transfer. And that's an important piece of it, because we don't need to know everyone's royalty rates. We don't need to know everyone's exact language that would lead to any proprietary deal information out there. But we do need to understand how many people are actually trying to make things equitable and accessible. We've tried to assess that through the voluntary report card. A lot of folks don't like to fill out the report card. So we're now just calling on universities to release information and track your own metrics and tell us how you're doing. And that's kind of what we'd love to see. And throughout that, we've identified some modalities, we call them. It came from my European counterparts, so I do apologize if modalities is not the correct term for folks. But thinking of things like licensing, spin-off companies, product development partnerships, and commissioned research, because technology has changed since 2001 when we were founded, since 2008 when we came up with our last set of frameworks. The ETAF is hoping to be all-encompassing and bring up many more. And to that end, if there's more ideas, more pieces, and more innovation that you don't find reflected in it, we want to add it. We want to think about it. We have identified some core principles: limiting monopolies as much as possible where it makes sense, as a big caveat, including margin or clawback provisions, reach-through clauses, retaining intellectual property rights everywhere where it makes sense, which, by the way, aligns with Autumn's core principles, almost word for word. And then social responsibility across the entire technology transfer space and licensing space, which goes beyond only access. We dive in a little bit deeper. Some of these things we know are still kind of under work, but we're talking about transparency, especially when public funding is involved, thinking through limitations or ways to waiver some forms of data and market exclusivities, especially when in low and middle income countries where it makes sense, accountability and transparency mechanisms, and of course, sharing data and research findings to make science more transparent. And then finally, we've come up with some draft mechanisms for accountability that I won't break down in deep detail here. But all that being said, we're in a spirit of collaboration. We want to work with you. We want to share ideas. We want to hear your ideas. We want to hear your critiques. And so I want to be open, transparent. Here's my email address to get in touch at any time, as well as our office phone number, which of course is US based. So do keep that in mind if you call with any kind of international roaming situation. But definitely, here we are. This is how to get in touch and keep in touch. We want to work with you. We want to build the affordable access movement. All right, I'll stop sharing.
Well, Justin, thank you so much. Outstanding presentation, and really does build on what Andy and Adam and Brett have been talking about this morning. So thank you very much for your presentation. We're going to do a session at the end, so hold online after our next speaker because we're going to do a bit of a Q&A before lunch. But thank you again, Justin, and take care down there in the US, okay?
Wonderful. How about now? Okay, perfect. Hi, everyone. It's such a pleasure and a privilege to be here with all of you today, presenting to you a little bit on my journey into global health and my story in neglected tropical diseases and health equity. My name is Aisha. And before I begin, I just want to give you a quick idea of who I am and where I stand. So a little self-location. I'm an African native. I'm a former refugee and a first-generation immigrant to Canada. I live, work, and play on the Algonquin Anishinaabe traditional territory known as Ottawa in Ontario. And my journey to education took me through biochemistry, epidemiology, and now pursuing my PhD in global health at McMaster University. And I think while my path came with several challenges, I also recognize the privileges that I now hold. And in global health, I think privilege really shapes whose voices get heard, who leads, who gets access to care. And it's something that we always should be mindful of. So that being said, ever since I was young, I mean, those are some embarrassing photos of me, but ever since I was young, I was fascinated by bugs and all kinds of bugs, the bugs that fly, squirm, crawl, jump. And I remember spending hours watching them in my backyard in the summertime. And as a teenager, I learned in high school that there are other kinds of bugs, pathogens, viruses, bacteria, parasites. And I learned that bugs like mosquitoes end up acting as bugs, as vectors for bugs like pathogens that spread disease at such a global scale. And that's when my curiosity began to deepen. And so after high school, I pursued biochemistry and I was focusing on microbiology, and I did an option in immunology as well to better understand the pathogens that mosquitoes carry. And so I studied how infections start and how they ultimately end. And in my final year, one seminar on malaria really changed my perspective, where I realized that mosquito-borne diseases aren't just biological events. They're not only, host pathogen interactions. There's a really big social element, and they're social events. They are events of poverty, of access and inaccess, and inequality and equality. And that's really what pulled me into epidemiology, kind of away from the microscope so I could see the bigger picture and try to understand the social determinants that really allow diseases like malaria to persist. And so I pursued my master's in epidemiology, and that's where I did my thesis at the Insight Research Lab. It's led by Dr. Manisha Kulkarni, who is a renowned Canadian entomologist and vector-borne infectious disease epidemiologist. And my master's thesis looked at the social factors associated with insecticide-treated bed net utilization and ownership among reproductive aged women in Tanzania. And that research ended up opening my eyes to something even bigger, that diseases aren't just biological, they're not just social, they are also shaped by the environment, and they're very much ecological, and that climate change is really reshaping the landscapes of disease, also expanding the reach of vectors and intensifying health inequities worldwide. And so that's when I began my PhD in global health to now try to understand the biological, the social, and the ecological. I like to call it the eco-biosocial determinants of vector-borne diseases that of all kinds of vector-borne diseases, but ended up focusing on one disease that's very notoriously hard to control, and that's dengue. So you may be wondering, Aisha, malaria is what got you into epidemiology. It's what got you into global health. So why do your PhD work on dengue? And I'll get to that in a moment. But first, I'll talk a little bit about what dengue really is. So dengue is this climate-sensitive vector-borne infectious disease. It's caused by the dengue virus. There's 4 serotypes that we know of, and it's mainly transmitted by the Aedes genus mosquito vector, largely Aedes aegypti and Aedes albopictus. And today, dengue is found in over 100 countries and territories around the world. And as many as 60% of global dengue cases come from the Americas region, where in Latin America and the Caribbean, where dengue infection is endemic, documented epidemics have become much larger, more frequent, and tougher to control. So in 2024, just last year, countries in Latin America reported more than 12 million cases of dengue. So that's nearly 3 times more than in 2023. And so it's really important to understand that dengue actually the transmission of dengue really functions within an epidemiological system or an epi-system. And to really elucidate this epi-system, I try to use something called the eco-health approach. So eco-health examines the relationships of factors at the human-animal-environment interface. So kind of like One Health, but it's a bit different because it has 6 principles, the first of them being systems thinking. And as you can imagine, that would be very useful for thinking about the dengue epi-system. And in the context of dengue, I use the eco-health approach to investigate the eco-biosocial factors that end up operating the dengue epi-system. And so why dengue at the end of the day? Well, it's because it's the perfect illustration of how the ecological, biological, and the social factors all work together to transmit this disease. And so during my first year of my PhD, I received the Research Award in Global Health from the International Development Research Center, or IDRC. And for those of you not familiar, IDRC is a Canadian government-funded organization that funds research in developing countries to address global health challenges like dengue. And not only did IDRC support my PhD research financially, but it was actually there where I met the founder of EcoHealth, the president of IDRC, Jean Lebel, and the one who refined the approach and added 3 more principles, Dr. Dominique Charon. And in my informal conversations with them, I learned so much more about the approach, how its application really in the real world from their book, EcoHealth Research and Practice. And I ended up building this really deep partnership and repertoire with IDRC that I continued to work with them as a program officer up until 2024. And today I still do a little bit of consulting with them. So applying the second principle of EcoHealth, I know this is a big slide here. This principle is transdisciplinary research. So my IDRC funded work brought together a diverse panel of dengue researchers, policy managers, and program officers from Latin America and the Caribbean to help work together to develop some kind of ecological, biological, social framework for dengue transmission and epidemiology in Latin America. And this is what it ended up looking like. So essentially on the left, the most left here, social factors exist at multiple levels, global, community, household, and individual. Then we have biological factors that involve the vector and the virus, and we later ended up including a human element to it as well. The biological factors and the ecological factors kind of work together through these arrows, and you could see that as well with the biosocial factors. And finally, the ecological factors end up ranging from macroclimatic factors to microclimatic factors, anywhere between big scale events like climate change all the way down to more micro scale events like urban heat island effects. And all of that is really connected in these arrows here. What was really interesting was that we also developed a policy and program framework to highlight operational gaps and opportunities in dengue prevention. And so the panelists highlighted that to overcome barriers to dengue prevention, and particularly mosquito control, what is needed are four things, and that's government investments, intersectoral approaches, innovative practices, and integrated programs. And ultimately, they concluded that the most important prevention measure was an integrated community-based approach, which really leads us to the third principle of EcoHealth, which is community participation. And so I didn't mention this, but the Aedes albopictus, the Aedes aegypti mosquito vector for dengue really thrives in urban environments. And hotspots for dengue in Latin America are several, but the most intriguing case is that of Sao Paulo in Brazil. Sao Paulo has a very high vulnerability to dengue, largely due to its optimal climate, its geography, its urbanicity. It's the largest city in Brazil. It's the economic powerhouse of what Latin America is, and it's the most populous city in the southern hemisphere and the western hemisphere. So it was really cool being able to visit Sao Paulo to do my fieldwork research. And so for my PhD, what I did was I explored how people in Sao Paulo understand and navigate dengue risk using a participatory action research method called photo voice. And so residents took their phones and took photos of dengue risks in their daily lives, like standing water where mosquitoes can breed, garbage buildup where they can also breed, as well as the high cost of repellents that they see, especially during epidemic times. And Sao Paulo saw the worst epidemic of dengue in history just last year while I was there. And so in focus groups, they ended up sharing their insights and turning their lived experiences into very powerful evidence. And by presenting these photos to local officials and officers, we ended up highlighting the need for community-driven solutions such as neighborhood cleanup campaigns and sanitation campaigns, as well as repellent distribution schemes, especially in more impoverished areas like the Brazilian favelas. And so principles 4 and 5 of EcoHealth, the EcoHealth approach, end up telling us that community-driven interventions are more sustainable, and they're also more equitable than top-down approaches. And by empowering and engaging communities, you can build trust, foster culturally relevant solutions, and also encourage prevention practices that persist long after the external support is there. And so time and time again, literature in the NTD space has kind of shown us that community-driven insights inform policymakers to design more effective and more equitable policies. And this is really something that I had learned firsthand when I served as the Canadian Youth Delegate to the World Health Assembly and the Pan American Health Organization Directing Council last year. And as a part of this Canadian delegation, I really had a front row seat at the high-level decision-making table at mainly PAHO, which was interesting to me, where policies had real regional impact, and those policies were often approved. And one key resolution at the PAHO Directing Council emphasized community involvement in epidemic forecasting. So there was a policy on epidemic intelligence for strengthening early warning systems for epidemics that was approved, which will certainly have very important implications for Latin America and for dengue. And that brings us really to the final kind of conclusion of EcoHealth, which is the final principle, the sixth principle, knowledge to action. And being at these high-level policy and decision-making forums taught me that building the research to policy pipeline is not very easy. It takes a lot of time, but it is very possible. And with the right tools and the right support, countries can integrate communities into public health strategies. And after PAHO DC last year in October, I went on to continue working with PAHO as a consultant at the Evidence and Intelligence for Health unit that really specializes in knowledge mobilization, knowledge to action, and taking research and converting it into real change. So how does this relate to the theme of this workshop? What does it mean for global health access and equity? What does it look like in the context of my research and other NTDs? Well, I think the lessons learned from community-driven research can really be applied to the other mosquito-borne diseases that we see in Latin America and we see all over the world. We can use these lessons to empower local action through other methods of participatory action research, not just photo voice, to highlight lived experiences. We can promote sustainable interventions by advocating for more effective prevention strategies and addressing structural inequities, and also building policy advocacy and research capacity through multi-sectoral coordination with communities for dengue and other NTDs that are spread by the Aedes mosquito, like yellow fever, chikungunya virus, Zika virus, and you could ultimately hit 4 birds with 1 stone. And so these are just some of the ways that we can use community-driven solutions to achieve global health access and equity in the fight against NTDs. And so if there's any, one key takeaway message here, it's really that the future of global health depends on empowering communities as active partners in disease prevention and also co-creating sustainable, locally driven solutions that address the root causes of NTDs, like the eco-biosocial factors, and also foster equitable delivery and access to care. And so just 2 months ago, earlier this year in January, Brazil's Butantan Institute ended up submitting documents for the approval of its single-dose tetravalent live attenuated dengue vaccine to the National Drug Authority. And so if it is approved, this will really render a dengue vaccine that's more accessible and more available to Brazilians at a much lower cost compared to importing vaccines from Japan, and also reducing the reliance on foreign pharmaceutical companies and strengthening national capacities to respond to dengue. So that's really exciting. And I think this will also present another access and equity challenge that Brazil will need to address. But coupling that with community participation and vaccine rollout might actually end up being very important to promote vaccine acceptance in Brazil. So I'm in the final stretch of my PhD. I'm writing my thesis now. And honestly, I actually don't want this to end. I think over the last 4 years, I've had the most incredible journey in global health. I've been privileged enough to win awards and present my research in Sweden and London. I've written about climate change and disease risk globally, but here in Canada as well. I've stood on some really cool stages, global stages, and been a part of conversations that end up shaping policy. But to me, I think if we're talking about a success story, it's really not about the awards, it's not about the publications. I think it's more so about the connections that I've been able to make and the impact of the work that I get to do. Because along the way, I've been able to make friendships and even learn a little bit of Portuguese, which is always great. And if there's, I think, one thing that I've ended up learning, it's that the path to global health isn't really a straight line. I know that I said that I was interested in bugs my entire life, but it wasn't easy getting here. It wasn't really as straight of a line as you might think. It's really winding, and it's a collective journey, and different minds and different experiences and different passions all come together to make change. And it's really about building people and working together as a community, like I said. So I don't know if there are any aspiring global health students in this room or maybe online. I'll just leave a few words of advice to those coming into global health. I just want to say maybe you should define success in your own way. Take all the risks that you need to develop a very interdisciplinary skill set. Don't just stick to research. Think about policy impact. Think about programs impact and local impact as well. Build really strong networks by collaborating with others, even if it takes you out of your comfort zone, and even advocate for yourself and for others and for your research and for the policies that matter to you. And always ask, who's at the table, who's left out, who should be here, and be mindful of that. Also, be adaptable. The world is changing so quickly. And so it's really important to listen and to learn and to be very open to change and to different perspectives and to be able to pivot when your project doesn't get funded. And finally, I think you should also remember your where, your why, who you are, why you're doing this, where you are. These are all very important questions. So awesome. And I think I'll just end by saying big thank yous. I wouldn't have had this story in global health without those around me who made it very possible for me. So I just want to take a moment to acknowledge all those who've helped me, my supervisors, including my PhD supervisor, Dr. Lawrence Mbagbo at McMaster University, all of my mentors, all of the institutions that I've been a part of, my funders, employers, all of those organizations that have helped me get to here today. And I also want to thank all of you. Thank you for inviting me. Thank you for listening. And I really do look forward to answering some of your questions and having a discussion. So, thank you.
Oh, outstanding presentation. Congratulations, Asha. That was great. I wish I was a student again. So we have a few minutes. I've saved the Q&A and the discussion for now. So we have about 15, 20, 25 minutes for I know, Brett, you have to head out for a few minutes. Do you have a few minutes just to okay, a couple of minutes? So I know we've had some outstanding talks. In the last two talks, my apologies, they were supposed to discuss success stories. So Justin talked about what UAM has done with a couple of the drugs, and Asha gave her wonderful story about her journey as examples of successes, building on what Adam, Andy, and Brett did earlier this morning, setting the scene about what's happening. So with that, any questions or comments for our speakers?
Sure. Thanks to all the speakers, even me. This is actually a question for Brett. We'll cross. No, I'm just very interesting to learn more of the details about what UBC is doing. And I was wondering, and maybe we can use an example that's been in the news recently, the new TB compounds at UBC out of Jim Sun's lab, where there's very impressive, if there's UBC, the press release folks, very good job getting that out into the media. But, you know, absent a bit from the press release was both the global access angle, which for TB is obviously a real cornerstone, and also the with this compound, indigenous knowledge element that, you know, bloodroot being used, you know, for medicinal purposes. I believe it was by indigenous groups within Canada. So I'm just wondering if you could expand a bit on the approach to those angles, including the public-facing aspect of these things, because, you know, when you're doing good things, you know, that would be something that would be great to hear about. And I think you know, to be more in the public eye when good things are happening, instead of, you know, people like MSF not always saying as nice things.
Yeah, that's a good question. So, you know, early on in my presentation, I kind of showed that UBC is a big place, and somewhat embarrassingly, I have no knowledge of these compounds. And that may be simply because they've been disclosed to my office and somebody else is working on them. Honestly, I think it's unlikely they have been disclosed to our office. So the process at UBC is, if you want to commercialize something, that's it's for the principal investigator to bring it forward and disclose. So I don't believe that. I couldn't say for sure. I don't believe that's happened. Certainly the UBC communications people never ask me about what they're about to communicate and to say good things about. But certainly, like, I will say, you know, a tuberculosis drug, absolutely, UBC would, I think, rigorously require global access provisions in any license agreement associated with that. I mean, that's a very clear example where it would be unacceptable to me not to. The use of indigenous knowledge is a good question. It's something we're working on in terms of. So again, I don't know the specifics of how that fed into this particular technology. We do take those seriously. We are, you know, there's kind of a tension's the wrong word, but I'll use the word tension. There's a tension between indigenous rights and academic freedom. And we've tried to kind of address that through a moral rights approach, to say, you know, we're maintaining the moral rights, to use kind of a copyright term, of the indigenous groups that are contributing to the project, which kind of allows us to don't write this down, anyone, kind of skirt around the academic freedom requirements of a university. So I guess all I can say is I'll look into seeing if we have received anything on this. I don't believe we have.
Okay, great. Other questions for our speakers? David, let me just give you the mic.
I was wondering if we could bring forward a discussion that was happening at the break that involved Adam and Srin and Rich, and we were talking about how things are changing in Canada with the biomanufacturing initiatives. There's the ability to prepare product, and there's the first in human capabilities that are coming online. But one still imagines the big capital limitation of funding major clinical trials. And I guess I was considering that to be a major limitation that meant that a lot of our patents go elsewhere, overseas or south of the border. But I did hear some good thinking from Adam and Srin, and I was wondering if you might want to reflect that to the room.
Okay. Srin?
Sure. Srinivas Murthy here at UBC. We were talking largely about the clinical trial infrastructure specifically. And I think one of the hobby horses of the world is that clinical trials are costly, expensive, and only one group of individuals can do them. And we know that's not really true. There's not really great transparency about the costs of clinical trials. And a lot of people are trying to focus a lot of energy on getting those costs of clinical trials more transparently available so that can feed into drug costs, that can feed into policy, and so on. But back to your question, Dave, in terms of how we actually bring a product forward, and there's lots of sort of novel models of public ownership of clinical trials and public ownership of the IP that comes from the clinical trials. And that idea is not a new one. It just needs to be sort of pushed forward by the relevant stakeholders.
Adam, you want to add it?
Yeah, just very briefly add to that. I mean, that is something that MSF we're really actively working on. In trials we've participated in, that we're really trying to push transparency, particularly around what it actually costs, to do these things. And that isn't free, but at the same time, to kind of give a more realistic picture of what it can actually be done for it. And that's true of many other aspects of drug development as well, that there's some numbers that float around that are perhaps a bit higher than they actually are. In fact, not perhaps, are a bit higher, and more transparency all along is good for everyone in terms of demonstrating what these things actually require in terms of resources, wherever those resources are coming from.
Great. Other questions? Rich, let me give you the microphone. Don't worry, I don't mind walking around.
Actually, I have one question from each of the presenters this morning, because I think you have such an incredible network of experience. And one of the principles that I know Brett mentioned for sure in the principles is the step-in approach. And I've seen it in Grand Challenges Canada, Gates, and so on, where the principle is that if they don't in a timely way commercialize to the population that needs it in a lower income country or something, that there's the possibility for the university to step in. And it sounds like a great principle. I'm just wondering, has there been any example of that yet that you're aware of, and how has that worked?
Does anybody want to take that on, or of our speakers, or anybody else? I don't know. It's an open. Justin, did you hear the question?
Yeah, I did. I actually.
Yeah, we can't hear you. Go ahead.
Oh.
We can see
Can you hear me
you.
now?
We can see you, but we can't hear you. Is it him or us? Okay.
Try again.
Try again.
Hey, can you hear me now?
No. Oh, now try. No.
And one more try.
Okay, there you go.
Awesome.
Third time's the charm. Go ahead,
There
Justin.
we go. Unfortunately, I have a disappointing answer, which is we have lots of examples of folks including or thinking about these clauses, but I actually haven't heard of an example of someone utilizing step-in rights at the university level. Now, I may be wrong in part because we have been pretty adversarial with universities in the past. We don't always get told about the examples. So there's a possibility that someone has utilized it and has some thoughts there. I would say though, in other spaces, it's very similar to compulsory licensing or margin rights when governments have them, and we've seen multiple governments step in with CLs or push for those and really transform the licensing dynamics and generic availability of products around the world.
I think, Rich, Adam and I were just talking. We're hoping to do that here at UBC with Oral Amp B, actually, to your point. The license has been brought back. It's been, and by the way, Dr. James Kim is in the audience, the CEO of Lucidex today. So thank you, James, for supporting the work. But I think he's worked with Brett and UBC Innovation, your new name now, used to be UILO, to maybe do something like that moving forward. But in the past, it was licensed out, and Ico Therapeutics, and I agree with Brett, we give them a shout out. They're a small biotech company. They got us all the way through phase 1B clinical trials on a small little company in Vancouver. So that was great. They just ran out of gas and it had to move forward. So, but that was driven by the company, not by the university. This, I think, might be a little bit different. So we'll see moving forward. But I don't know examples either, actually, Rich. It's a very good question. Anybody? Oh, yes, Andy, please, let me give you the microphone.
Thank you. Yeah, I don't know any examples either. The only thing I was going to add is, I mean, I do think it's important for offices to have a whole host of clauses that, Brett, I don't have to lecture Brett or anybody else in here, but they know that. The issue in my mind about thinking about one clause as being more important than the other, or like step-in rights being a more important thing than, for example, the Affordable Access Plan provision. I mean, it really depends how the clause is drafted and also what the technology is. Because, I mean, again, and we talked about this before, but if it's something where there's only really 1 or 2 patents, is very simple technology, then yes, like the having a right to take that back is obviously going to be very important. But if it's or the know-how of something becomes more important, then I actually don't know that it becomes the kind of backstop that Justin mentioned before to like make other things work better, because what does it do to get that patent back when you still have other things? So I think it's important to think about these things kind of holistically, right? Like when you're trying to accomplish access, like yes, having that right to take something back or to issue a humanitarian license, like those are important, but in practice I don't know what they would accomplish. And so that's kind of why I think the access plan provision that we've talked about so much is so important, because you're actually putting the thought in ahead of time to make sure you don't have to even think about having that fight. I mean, the step-in rights thing or a humanitarian license, like those are going to provoke much more contentious discussions than having the conversations about what are we going to do here about access, right? Because you're actually talking about pulling something back. And that's why, I mean, even outside of the university licensing context, and as Justin mentioned, like when you talk about national policy, like these are not easy conversations, right? These are polarizing conversations, and not the kind of conversation. I mean, and I'm not weighing in one way or another on whether it's right or wrong, but that is the reality. Is that those conversations are extraordinarily difficult, and so what is it that we can do, knowing that is extremely difficult? Like, how can we advance this here? I think you kind of need to think holistically about the types of clauses and approach.
No, excellent comments. Other thoughts? I do have a question actually for Justin, Adam, and Andy. Because of your 3 organizations, what has been able to give you the ability to freedom to operate? In other words, because of our heightened political climate, I'm not asking you necessarily how you're funded, though indirectly I am, I guess. I mean, how are you able to stay above the fray from a political perspective in terms of the fact that you guys are all advocates in different aspects of this work where you don't have the political pressure from a pharmaceutical company or from governments or a government agenda and so on. How are you able to have that freedom to operate? Any one of you are willing to take that on?
I can go first, I guess.
Okay, go ahead, please.
So,
I'm going to hand you.
I mean, the stakeholder balance for MPP is, as I mentioned before, like very tricky. To put it very, I don't know. It's not easy, but I mean, we have the support. We do our best to walk that line and to make everybody happy. Sometimes we don't, sometimes we do. But through that, we have the support of various governments, and have been able to do the work that we need to do. I don't know if that's answering your question.
The reason why I bring that up is because you're saying you've got governments that are supporting you, but I guess the question is, but if governments change or policies change,
Yes.
how do you adjust to that?
Yeah. So I mean, Unitaid remains our major funder. So and the changes in the political landscape may have an effect on Unitaid as well. They rely on support from governments also. But it is a bit of a stabilizer for us, like, because if they are funding the bulk of our work, but then we have additional resources that come from, for example, France or Switzerland or Germany. The political landscape may change. Those things, who knows what's going to happen, right? It's scary, but we're lucky for the moment, at least, to be able to continue to do what we do.
All right, since I feel like I've talked a lot, but I mean, MSF, I think there's a couple of factors. I mean, one, just since you spoke to funding, I mean, we are, I had the exact number on my slide, it's 98.1, I think, percent, private donations by individuals and so forth. We actually do accept a tiny little bit of funding from like 3 governments in the world. Canada is actually one of them. In very limited circumstances, but that independence, I think has been very helpful to us in a lot of our advocacy and also humanitarian as well. But I think even more than that, I think is that the end of the conversation, that we think that everybody should have access to the medicines that keep them alive. That end point is really kind of hard to argue against. There are certainly conversations, about how to get there, and very legitimate conversations about how we get there. But at the end of the day, that's our goal. That's the goal of most of the folks that we'd be interacting with. So, I think that is also, very helpful in this conversation. Being right is,
yeah. And the reason I ask you, and I'll ask Justin, I'll get your comment in a minute. The reason why, Andy, Adam, I give you a hard time about being provocative. It's because you actually do wonderful tweets or X's or whatever they call it now, but you get us thinking. But the question, why I bring up the question is you do challenge the system. So you need that ability to freedom to operate if you're going to challenge the system. And so that's why knowing how you're able to have that freedom is actually critically important, because sometimes a government does a policy that you don't like. You don't want to have that same government that's funding you, right? So I'm just curious why. Justin, your thoughts, how has UAM gotten the ability to do the advocacy work that you've done? Because you've done amazing advocacy work.
Thanks. Yeah. So for us, we're almost entirely funded by private foundations and then individual donors, mostly alumni of our organization, on the individual donor side. So that freedom really comes from that. And then we also have the advantage when it comes to the policy landscape and governments changing over. We have the advantage and maybe severe disadvantage that we've never agreed with a government that in whole, right? Not in North America. Oftentimes the Canadian government's closer. to what we agree with, but actually there are solid critiques, including a paper referenced earlier on what the Canadian government did around vaccines in COVID, and nothing like COVID showed us a better picture of how much we weren't aligned with any particular government actor. And it just happens to be that we don't have any other funding. So we're able to do the advocacy because we're completely independent. We take no pharmaceutical industry dollars, and we're mostly funded by those individuals. And then also because we're driven by our membership. If our membership really wants to pursue a new topic, we go for it, which means that student voices, alumni voices, and now research and faculty member voices are heard across our organization.
Okay, great. No, thank you very much. By the way, I think you might have forgotten, you and I first met Central Michigan University back
That's
in
right.
2011 at a UNA conference. Stephen Lewis was there. I remember that. You haven't aged, Justin. I have, but you haven't. I mean, you look great. Any last question? I got to get that because it's on the video, so it makes it look clear. Any last questions or comments? Please, we're about to have lunch, and then we're going to be doing the workshop portion of the event. So I hope you will stay and not take off after lunch, because there you will have more of an opportunity to provide your feedback and your input as well, not just a Q&A. So any last questions? James, let me just
Yeah, speaking as sort of, I think, the ugly duckling in the room, coming from industry. This, I think, is more of, I'm just throwing it out there. It's continuing discourse that I think we need to have, but because the comment on, the public funding coming into running clinical trials and public ownership of IP, I think, modern history has taught us that the profit motive is the single strongest driver of faster development to market and bringing products that save lives. It's unequivocal. And we all also understand, due to various reasons, that public discourse and public ownership tends to delay, to a certain or severe degree, these types of developments. So then especially, like, I advocate MSF and have been doing personally for a while, and I'm also very vocal about some of the opinions that I'm against. But why? It's great. I mean, the discourse is great, but why then do we not have strengthen the profit motive, especially? And I'm doing a lot of work in Africa as well. I'm wrestling with like Ugandan universities for IP, like as we speak. Why not strengthen the profit motive in those countries as well? Because they also need to develop their R&D capacity. They need to develop their industry as well. And then wait until the IP runs its course, because it eventually comes to an end, and then genericize it. Would that not be an alternative route to wrestling tirelessly with some very unsavory actors? I'm part of industry, but there are some very profit-driven people that you do not want to associate with, and wrestling with them and trying to get these drugs into clinical trials that take years because people are dragging their feet now. What's your opinions on one approach versus the other? Of course, like, these are two extreme examples here, but what do you think? Wouldn't it be a better approach just to strengthen the profit motive and really, have generic manufacturers, developers just, come in full force the minute these things run out, as opposed to, wrestling and using public funds and dragging the development?
I think Adam wants to respond.
The mic here, but I do want to make sure that everybody gets a chance to talk, not just me all the time. So, I mean, one of the issues with that is, if there's an outbreak today, rather not wait 20 years to respond to it, in the right way. The current biosecurity model, has spurred some innovation. It's, US in particular, but Canada has some surprisingly large stockpiles of some things, that has been a motive, that has spurred some innovation that might not have happened otherwise. That's probably a positive thing. But what's the next step? And it's come up again and again here of, what are the countries you're not marketing to? How do we actually, and we can frame that. This is not usually how MSF frames things, but, if you're selling a bunch of things in one country and you're not selling it all to the other country, are you leaving money on the table? Isn't it better, a better business to make sure everybody has access? Isn't it, honestly, if we're again talking biosecurity kinds of diseases, isn't it better biosecurity to make sure that you've got your stockpile, but also where the outbreak is, it's getting addressed, the fire's being put out before it spreads? Those things don't really work as well on a 20-year timeline. Now, there's a whole different conversation to be had, about some of the existing innovations that are disappearing, from the market, right? The cholera vaccines, those sorts of products, where, when we're talking about local production and how to make these things happen, there are conversations. I mean, there legitimately are. And, I'm wearing my MSF hat here, and I will still say, there are some products that we probably aren't paying enough for. The thing is, those are not most of the new university IP sorts of products we're talking about today. These are the innovations that have already got to the stage you're talking about, that remain vital, but no longer are viewed as not necessarily unprofitable, but not sufficiently profitable to keep in production. So yeah, I mean, there's a conversation there, but there's a lot of health products, and there are different solutions to different ones. And yeah, that's a relevant conversation, but perhaps not really as much to the licensing one I think we're having today.
Actually, I was going to say almost the opposite of that, I think that's a really interesting question. It's one of those provocative questions. What I'm going to say differently from what you just said, Adam, is that it seems to me this is kind of the crux of what we're talking about today, is how do you create incentives for private firms to engage in this process? And there has been a lot of economic literature asking what happens to neglected diseases, the innovation of them, the licensing of them, as a result of strengthening patents in low and middle income countries. And they found that while strengthening the patents does not actually increase research in neglected diseases, what it does do is what you said, is speeds up the process of delivery and of having access to them. But the question I have for you is, and there are other incentives that have been discussed, which I might be interesting for the medicine patent pool, which is there seems to be also strategies that private sector is using. For example, they recognize that, sure, they can deliver innovations, their medicines in low and middle income countries, but there's not necessarily a trust there. So they're grouping up with generics and creating these branded generics and that sort of thing. But the question to you, though, is when you say, let's wait for the patent to expire, and I agree with Adam on that, if there's an outbreak, you need to deal with it right away. But we also know that it's so easy to patent an improvement of a drug. And so the patent isn't necessarily going to expire after 20 years. It could be another 20 years in which the improvement is patented, and then another one. And so it's unclear when the innovation is going to be made available. And that's why it's so important to come up with these licensing arrangements that will bring in the pharmaceutical companies without having the patents and having those kind of monopoly rights.
Okay, I think because lunch has just arrived and it's nice and warm, and we can have these conversations during lunch. So I think let's thank all our speakers. Let's give them a round of applause and thank them very much for this. Outstanding. Justin, thank you for beaming in from Michigan. So the plan is this: we will have lunch, and let's reconvene at 1:10. It's already 12:20, so you've got 50 minutes. Have some lunch, relax, spend some time with your colleagues. And then this afternoon, please come back, because now we're going to do the hard work of the workshop. This part will not be streamed. Okay. So thank you very much, everybody.